give you the changes, the reductions that we made, and the reasons for it, and to just paint a picture of the Department of Human Services, what we do, what our challenges are, and how that fits in with our budget, and how we try to align our budget with the governor's strategic plan. Let me start by saying very quickly our vision, mission, and core values. We are about stronger families for a stronger Georgia. We want to strengthen Georgia by providing individuals and families access to services that promote self-sufficiency, independence, and protect Georgia's vulnerable children and adults. Everything we do is geared around that foundation. Let me go into our current resources and initiatives. We see here on the pie chart slide that we have for base budget for fiscal year 13 a little over $1.3 billion budget. About 63% of that is federal, around $853 million. About state is 34%, or $458 million. We have a small amount of tobacco funds and a small amount of other that are outlined there, and I can answer any questions about those if you have any. The uses of our funds primarily are for the Division of Family and Children's Services, about 75%. Our Department Administration or support is around 7%. Our Child Support Division uses about 7% of the funds, residential child care, which is child care licensing, about 1%, and our aging services, 10%. Some of our initiatives that we are undertaking now in the present year and in the year to come revolve around safety. As many of you know, in Fulton and DeKalb counties, we are under a court-ordered consent decree for child welfare. So we want to perform well with regard to that consent decree and the outcomes outlined in it so that we can be released from that consent decree. And I will talk a little more about that as we go through some specific case numbers. We also, when I came to the department, I began to talk and put an emphasis on safety for children and let that be the first thing we look at. As a result of that, we have been moving toward a new child safety model that we call differential response, which is a part of that, which just essentially means that we have more of an ability to track situations after we have initially looked at them to determine whether or not we need to take some action in the future. We also want to increase our number of problem-solving courts. Problem-solving courts are an alternative court within the child support arena. This allows judges to work with non-custodial parents to help them find employment and education to help them be able to pay child support rather than being incarcerated, where obviously they cannot do so. Within our aging division, we are working on transitioning individuals from nursing homes into the community with a purpose of helping elderly Americans and Georgians live in the community safely. And we have a contract with the Department of Community Health to use part of a grant money called Money Follows the Person to move money with a person from an institution into the community. We also want to be a more efficient department. We want to have better infrastructure. We want to have a better eligibility system, and I'll talk more about that later. We want to have technology to help us leverage budget reductions and staff reductions. And we want to be supportive at an enterprise level across the department of those programs, be it DFACS, child support, or aging. Can we give them the technology, the financial support, legal support, et cetera, to do what they do? I wanted to tie very briefly back our budget to strategic plan measures. Some of our major goals are, one, we want to increase the Money Follows the Person transitions from nursing facilities to the community from 125 to 375 over a 3-year period. We want to achieve substantial compliance with the KENIA consent decree by improving our outcome attainment from 61 to 88% by December of 2014. We want to replace our success system, which is our eligibility system for our DFACS workers in all 159 counties around the state. We want to work with community health and public health, which we have been doing on our procurement, to have a new eligibility system that is state-of-the-art and that is funded by primarily by Medicaid federal dollars. I'm sure Commissioner Cook will talk some about that after me. We want to increase our citizen self-service capabilities to allow technology to allow people to apply for our benefits and services online, prevent them from having to use so much paper and from also having to actually appear at a DFACS office. And as I said, we want to increase the number of problem-solving courts to the ultimate goal of making certain that more money can get to custodial parents to help children. We currently have 6 active, and we want to go to 24 by 2016, and we've made good progress in that regard. Let's go over to our current and prior year funding. This chart just shows you a progression of where we were with funding in 2009. We were about $1.2 billion of federal and $629 million of state funds. Now you see in 13 we're at 884 and 455. This just gives you a flavor and an idea of the effect of reductions on the department in the past 5 years. A lot of our budget is based on demand for services and caseload growth. The way in which we approach the budget reductions and the way in which we approached our programs is based on trying to keep up with the demand for our services. If we look first with regard to Division of Aging and Adult Protective Services, you'll see that we have a little over or around 13,000 cases with a little under 230 workers to address those. For the Division of Family and Children Services for child welfare, we're around 1,700, 1,800 employees, and you see the cases there. So we really have a pinch, really have tried to not overload our caseworkers with individual cases, but it's a very difficult challenge to manage. The next slide shows you more particularly our average caseload sizes, and this is where I want to talk just a little more about Kenny A. You'll see the Region 14, R14, the purple line stands for Fulton and DeKalb counties. And the reason the caseloads are low in that region is because we are mandated to have certain caseload sizes by that court-ordered consent decree. That necessarily skews the rest of the state. We have to put an inordinate amount of resources in those 2 counties, and therefore you'll see for the red line, non-Region 14, which is the rest of the state of Georgia, we're at a high level, over 17 cases per worker. And then the blue line, which is combined, we're around 16. So it's very important to me that we perform well in Fulton and DeKalb, comply with the consent decree, achieve what we can call substantial compliance, and exit that decree so that we can begin to maximize our resources across the entire state. DFACS does eligibility for Medicaid, for the SNAP program or food stamps, for TANF, temporary assistance for needy families, and for child care subsidy in every DFACS office throughout the state. So we have an integrated eligibility system here where we work with the Department of Community Health to determine eligibility for Medicaid, and then for the human services benefits that we administer. So as you can see, and this is in large part a measure of the economy of the last 5 years, we've had a tremendous uptick in the number of cases. We're over 1.6 million cases or demand for eligibility services, and we've had exponential growth. Our thought and our hope is that as the economy gets better and begins to recover, that we'll have a sort of a flat lining of this number, and it will not continue to rise at the level that it is, but it's been a challenge and continues to be for our workers, as evidenced by the next graph, which shows you that in 2004, we were about 379 cases per eligibility worker. Now we're up to 793. So we've had attrition in staff, attrition in budget, and also a great increase in the demand. The next chart is, shows our out-of-home care placement. Out-of-home care is services and facilities for children who've been taken out of their homes for a period of 24 hours or more and who are being served and provided services of some sort in a setting out of the home. You can see the trend there. We've had some decrease, and we're right around almost 11,000 placements, and you can see the dollars associated with that, and where we are now is around 127 million federal and 88 state. I want to talk about temporary assistance for needy families. We get a TANF block grant, which has been around almost $370 million. Last year, Congress took away what we call TANF supplemental funds, and these are funds that were designated for 17 states, mostly in the South, to account for, I believe, their increased demand for social services. And as a result of federal budget deliberations last year, that money was discontinued, so we lost $37 million. I think this is the last time we'll actually be talking about this because we baked it in to show the reduction, but now that it's no longer there, we think the TANF block grant will be at that $330 million figure you see there. So we had to take the $37 million out of various programs, and if you wanted more specifics about the actual amounts that came out of each program that added up to that 37, I could provide that to you. TANF has a maintenance of effort requirement. This means that the state is required, in order to get that full 100% amount of the block grant, that we are required to provide a state match. Based on the amount of the grant that we get, our state match is a little over $173 million. Because of budget cuts and reductions, we have had difficulty in accommodating that with 100% state funds. So we have had to get creative to go out to private resources and have them contract with us to provide in-kind services that can be considered TANF allowable expenditures. You see, we've become quite dependent on that. We're at now 60% of our maintenance of effort comes from outside external sources and 40% from state sources. We do have a maintenance of effort requirement with regard to aging as well. Aging, the maintenance of effort is required is about $22.7 million. From the 2013 budget, we're a little over that. When we go to the reductions for 2014, we'll be right at the maintenance of effort level for aging. Basically, we're required to provide state funds that are at least equal to the average of non-federal funds spent over the past 3 years for aging services. So it's very important that we try to maintain that figure. Now let me go over a summary of the budget. First, in regard to that, let me talk about how we approached the budget and what it is we were trying to do and what our reduction strategy was. We want to strategically manage our available resources to strengthen children and families, which is our job, and vulnerable adults. We want to promote safety, self-sufficiency, and efficient safety network. We are essentially the safety net for many of our citizens. So our strategy involved, we had 3 things we said we do not want to impact in a negative way when we approach our reductions. We didn't want to do anything to impact the TANF MOE. With regard to that maintenance of effort, it's a double whammy if you don't meet it. If you're $1 short of your maintenance of effort, that is added on the back end to what your requirement is for state funds. So for every $1, you're essentially losing 2. So that's very important that we try to maintain that. We also are at a point where we really need to make sure that we have sufficient staff and resources to ensure safety of our children around the state. And we didn't want to reduce staffing or funds in the eligibility programs because, as you saw, the demand is very great based on the staff that we have. So those were the approaches that we took. Let's look now at a budget summary of the governor's recommendation. You have for amended fiscal year 13 current budget of a little over $456 million. The governor's recommended reductions that we'll talk about are around 4.6. We have statewide adjustments of 1.8 million, and we come out with a recommended budget for fiscal 13 amended of $449,563,000. Let me talk one time about what these statewide adjustments are, because as I go through the program by program cuts, they're going to be consistent across both years, so I'll say one time what they are. For fiscal year 13 amended, we have reductions or cuts for telecommunications expenses. This is for the GETS program, AT&T and IBM. And we have property liability premiums where our rates were reduced, so we have somewhat of a credit there. For fiscal year 2014, we have increases that were accommodated to us for our share of the employees' retirement system and for our TeamWorks billings, or as you know, probably know as PeopleSoft. We also have some reductions in state funds to accommodate a slight increase in the FMAP rate. So those programs that are subject and can avail themselves of the Medicaid federal participation rate, with the federal share going up a little bit, then that will allow us to reduce the state share accordingly. So some of the adjustments relate to that. Then we also have adjustments in 14 for telecommunications. There are some services here that are primarily federal funded, and they're not reflected in what we're going to show you this morning, but we can certainly provide program by program information to you and answer any questions about that. But for example, in adoption services, we have a retirement system adjustment. Also in child welfare for 14 and for our federal eligibility benefit services, we have adjustments in telecommunications, TeamWorks for 13 and 14 that are reflected in these overall numbers. So for fiscal year 2014, our current budget is $456 million. We have reductions of $3.1 million. Adjustments of $916, and we come out $451,987 for fiscal year 14. I'm going to go through now specific programs where we did take cuts and reductions. First, we'll talk about child care licensing. This is the unit that inspects, monitors, and renders enforcement actions on facilities that provide the out-of-home care that I referred to. We start out with a $1.58 million. We have adjustments in 13 and 14, and this adjustment reflects the elimination of funding for one vacant surveyor position. So that's the 47 for each year. We have some retirement system adjustments for 14, and we come out with the recommended amounts you see there for 13 and 14. In our child support services division, we took some fairly substantial cuts. Of course, we're at a point where our cuts are not optimal in any situation or in any program or in any place. So none of this is meant to indicate the lack of importance or lack of emphasis on a particular area. We just had to find reductions where we could. We start out here in 13 with $24.6 million. We have reductions which include reducing travel, eliminating 35 child support agent 2 positions. We have a state-federal match of around 66 to 34% in child support. So when we have a reduction in state funds, it results in almost a 2-to-1 reduction in federal funds. But what we have reflected here is only the state fund amount. But you'll see that we come down for 13 to $23.9 million, and for 14 for $24.384 million. Our child support division operates in a very effective fashion. In fact, the National Child Support Enforcement Association in last year, 2011, deemed our child support program the most outstanding program in the United States. So we're very proud of that. We're very cognizant of trying to maintain their productivity, and we will keep a watchful eye on that. Next, we go to Departmental Administration. Our current budget of state funds is around $37.5 million. We have GETS expenditures adjustment of 1.4. We have other reductions. We're going to reduce our personal services. We're going to reduce our operating expenses. We're going to reduce our contractual services for information technology initiatives and our computer charges. So we've taken quite a bit of a reduction in administration, and that's just something that's necessary for us to do. In 14, we started out with the same 37.5. We'll have adjustments that will be a bit higher. In 14, with regard to telecommunications, we'll have the other concomitant amount for 14 for the specific reductions I referred to, and we'll have a budget administration proposed of $32.5 million for 2014. The next few slides will talk about our aging services. The same comments with regard to child support are applicable here as well. We have a tremendous staff that does great work, and we're very mindful of trying to minimize any impact of budget reductions on their work. 2013, we have a current budget of $14.2 million. We have 55,000 elimination of 2 positions for a category called family service workers, and I'll be happy to answer questions about that if you have them. For fiscal year 14, we have a retirement system adjustment, and we have the elimination of 17 positions in the family service worker arena. Let me go ahead and just say a few words about that. These are a category of workers that we wanted to move into adult protective services and to increase our case workers. So irregardless of budget considerations, we're going to move toward making a change in this area to reorient the services provided by these individuals to where they're more needed now in the current climate. So we will be mindful as we move through here about ways in which we can mitigate any impact on actual people, but we do need to take a cut to move in a different direction in aging from this type of category of worker to one where we can use their services as case workers. Elder community living services. These are the programs that provide a continuum of support to seniors, adults with disabilities, and their caregivers to enable them to stay home and in the community for as long as possible. We start out here with a current budget of state funds of $66,713 for both 13 and 14. We are able to take over a $2 million reduction in fiscal year 13 amended with regard to the community care services program. This is a part of the Medicaid waiver that we work and contract with the Department of Community Health to administer. The overall waiver, which is, you probably know about a program called SOURCE. In addition, the CCSP is one large Medicaid waiver. They reached a caseload limit or a placement limit within the waiver under Medicaid regulations and CMS. So we had to cease input into the program, cease providing services for the fiscal year. And so we're able to take that moratorium, as it were, on increasing services or bringing new people into the program, and able for 13 amended to use it as a proposed reduction. So we end up in 13 with 64.74 million. In 14, we're going to have, we won't be able to use that CCSP reduction, so we're proposing a cut in respite care and Alzheimer's services, and we're proposing to transfer our contract with the Center for Visually Impaired for helping elderly, visually impaired people, to transfer that to the Georgia Vocational Rehabilitation Agency, their vocational rehabilitation program, and I can talk a little bit about that when I get into our attached agencies. Elder support services, we're at 1.736 million for 13 and 14. What we propose for 14 is to transfer some money between our elder community living and elder support services that we get from tobacco funds. We thought with this transfer we can better align programs and the use and the cash flow of tobacco funds across the fiscal year, and it will allow us to make the adjustment you see in 14 for elder support services. For out-of-home care, we're at 67.6 for 13 and 14. We're going to have a one-time operating expense reduction of $50,000 for each year, and we'll have in 2014, the $65,000 you see is related to the FMAP rate adjustment, so we'll be able to take state funds out with the increase in the FMAP percentage. Let me talk a little bit. So those are the programs where we took our reductions. Those are the programs where we have our cuts to get to the summary figures that we showed you. Let me talk for just a second about some issues and challenges and things that we're going to want to talk about in the future years, hopefully as the economy gets better. We would like to be able to, in the future years, increase our funding for staffing in adult protective services and child protective services. Child welfare is an arena where we can try to leverage technology on the eligibility side to help us accommodate increased demand for services. But on the child welfare side, people actually make a difference. You can't send a computer out to do a home visit. So we really need to try to reorient our staffing so that we concentrate and put an emphasis on the child welfare side. and we think we're pretty much at a floor with regard to what we're able to provide now for what we're required to do. And so in future years, as hopefully things get better, we would like to talk about that. In adult protective services, you saw that we had about 230 individuals to work on aging services. Unfortunately, there is a tremendous increase in the of elder abuse, both physical, emotional, and most importantly, as we get into this age, financial abuse. And so we want to do a better job of trying to detect, prevent, and enforce the abuse, neglect, and exploitation laws that are there. And to do that, we would like to have more staff in future years, resources accommodating that. I talked about our eligibility system that we're working with community health and public health on. So this is an area where we can have a state-of-the-art, modern, updated eligibility system that is essentially web-based, and that will allow us to leverage technology to help us reorient our staffing. So there are certain funds that we're able to tap into because we're working with the Medicaid agency, but there are certain costs that will be solely those of DHS to bear, and so we want to be mindful of that going forward. Targeted case management, we have made a decision, and I think it is a good one that I wholeheartedly support, to move the medical care of our foster care children into a managed care network administered by the Department of Community Health. Commissioner Cook and I have had many discussions about this, and we both feel that this will lead to greater continuity of care for our foster care children as they move from placement to placement. Doctors will have the ability within a network managed team to know what services were provided and what the children need. There's a bit of a disjoint effort now when children move around from physician to physician for many different reasons, and so we think this will help. However, now under our current system, DFACS is allowed to draw down federal Medicaid money for essentially being the children's parents and being able to make medical decisions for them. To the extent that this will be transferred to a managed care provider, we would potentially lose these funds, and so we would have to find a way to deal with that. But irrespective of that, I think it is a positive development going forward. Then we don't know, of course, what's going to happen with the federal appropriations, with the federal budget, so we have to be mindful, and of course it's not just us, it's every agency, of what potential impact that may have on us. Let me conclude by going over our attached agencies. We have 3 primary attached agencies. For those of you not familiar, an agency can be attached to a larger department and are charged with providing them with administrative support, infrastructure support, whatever they may need to do their business, and they may not have the resources to do that. The Council on Aging is one of our attached agencies. You'll see that they have a $205,000 budget for 13. They're going to lapse a vacant position, which will provide the cut in 13. In 14, they got a retirement system adjustment, which would, in conjunction with that lapsed position, mitigate the impact on them in 14. Family Connections is another of our attached agencies. This is a statewide network of county collaboratives to which we provide money, and then they go out and provide services for children and families within their local communities. They start out with a little over $9 million budget. They're going to have a reduction of around $527,000, which includes eliminating 2 vacant positions and having a fund source swap from state funds to use Medicaid funds. Our largest attached agency is one we're very proud to be associated with. If you recall, last year the General Assembly made a decision to move the vocational rehabilitation services from the Department of Labor and create a new state agency called the Georgia Vocational Rehabilitation Agency. They were administratively attached to the Department of Human Services, so we have worked with them to stand them up last July of 2012. We helped them with IT support, financial support, infrastructure support, of Human Resources and Contracts. And their executive director, Greg Schmieg, is here today if you have specific questions for him. But what you see here outlined is their budget for 13 amended and 14. They start out with a little over $20 million. They have essentially 5 major programs: the Business Enterprise Program, they have an administration program, they have a disability adjudication section, the Georgia Industries for the Blind, Georgia Roosevelt Warm Springs Institute, and their largest program, which is the Vocational Rehabilitation Program. You'll see that they're taking a cut in personal services out of administration. They're transferring some money from one program to the other to accommodate some of the medical costs at Warm Springs. Out of the Voc Rehab, that figure is mainly for personnel costs and also for the transfer to Warm Springs. In 2014, you'll see reflected there also personal services cuts. They were able to go through and look at the persons that transferred over with them from the Department of Labor to look at the utility of certain positions and services, and they made a decision to eliminate 17 positions, which will allow them to accommodate that reduction in their proposed 3% reductions for 13 and 14. As I said, Mr. Schmieg can answer more program-specific questions if you have them. So, Mr. Chair, that concludes our presentation for 13 amended and 14. I'd be happy to answer any questions that anyone had.
Thank you, Commissioner. We have a few.
Okay.
Senator C.
Thank you, Mr. Chairman. Commissioner,
Yes.
I am going to take up on your offer to request the loss of TANA. If you can give me that breakdown on that,
Okay.
I appreciate it. Thank you.
Okay.
Now, the question is, the governor recommended eliminating 35 positions, vacant positions from child support services. Were these positions vacant due to cuts in previous years' budget? That's one question. The second one is dealing with aging. Georgia has the 9th fastest growing over 60 and the 18th fastest growing over 85 population in this country. What is your department doing to address the needs of the aging population?
With regard to the first question, I believe not 100%, but primarily those 35 positions were vacated in previous years due to previous cuts. We've tried to, since I've been there, insulate child support services from many of the reductions. This year we were not able to do that. So these are not actual people working right now. These are vacant positions. And as I said, we are very mindful of maintaining their effectiveness in the work that they do. And so we had to find reductions somewhere, and this is one area we took them. But we will work very hard to see that it does not negatively impact what they do. But I think that's the answer to the first question. The second question is, we have a very robust division of aging with some very committed and dedicated people. We realize the increase in the elderly. It's almost a new population we're dealing with. We have people from the ages of 85 to 100 that in some sense have never existed before. So as a state and as a department charged with helping them, we have to change with that. So as I said, we really want to look at in the future greater resources for adult protective services. We are working with numerous state agencies and outside parties, including the Georgia Bureau of Investigation, to beef up the enforcement potential and capabilities of law enforcement to be able to prosecute elder abuse and to ferret it out. But that is an area where, as times get better, we would be able to benefit from increased staff. No question about that. With regard to the TANF reduction, the $37 million, the breakdown is as follows. We took a little over $1 million out of child care licensing. We took $600,000 out of child care services. We took a little over $10 million out of child welfare services, $5.6 million out of home care, Family violence services, a little over $10 million, which we were fortunate enough to be able to replace with state funds last year. A program that we call Support for Needy Families, Basic Assistance, we took a little over $1 million. For agencies where we use some of the TANIC Bluff grant to transfer federal funds that are appropriated to us to other agencies, we took almost $9 million from the Department of Behavioral Health and Developmental Disabilities, a little over $6 million from Public Health, and about 1.2 from Family Connections. So that was last year. I don't think we'll be talking about the supplemental going forward because that's just going to be baked out of the total block grant.
Thank you. And if I can just get a copy of that, I wasn't able to get all of them as you went through them, but thank you so much.
We'll do that. Thank you.
Senator Sims.
Thank you, Mr. Chairman. And thank you, Commissioner, for a very detailed report.
Thank you.
My question has to do with managed care. Are we creating another level of physical intervention and obligation? Could you go back and explain that to me? Because I think you said that was you would transfer it from your department to public health.
Well, no. Currently, we have around probably a little over 8,000 children, the number changes weekly, who are in state custody, we essentially are their parents and they are in foster care. Right now, we help determine their medical care on a fee-for-service basis with physicians. What we have agreed to do is for the Department of Community Health, through their Medicaid managed care program, to carve out foster care children and have one managed care network that's statewide that will help coordinate and provide and manage their care. We think this will increase and improve the continuity of care for these children. And so that's what I was referring to.
Thank you.
Thank you.
Senator Tate.
Mr. Commissioner, thank you so much for your presentation and all that you do. We've had a good working relationship, and I appreciate what you do for Caristeel Pitts, and of course you know my feelings on that.
Yes,
according to research, 25% of foster children end up homeless and 25% of male foster children end up in prison. Only 3% of foster children graduate from college. It is imperative that our state do as much as we can to ensure stability for these children. One way to do this is to make sure that where possible, foster children can stay in their school of origin, which of course Caristeel Pitts does a wonderful job of that. What effort is your department making to keep children in their school of origin, and does a lack of financial resources hinder this effort?
Well, I'll answer that in two ways. First, with regard to educational stability, it became clear to me this is a very important issue that we needed to address. The Department of Education has what they call a longitudinal data system, which is essentially a system that tracks the grades, the schools, the courses, the tests that a student takes from kindergarten through 12th grade. And any parent has access to that and can see what their child is doing. Well, we as parents of these children essentially did not have access to that. So when we try to make placement decisions for children, we're sort of flying solo with regard to where are they performing well, where should we try to make sure they don't leave when they do have a change of placement and you have to wait for the records. Sometimes with the older children, they lose credit. And so it's an area where we really needed to address. So we have, last month in fact, entered into a memorandum of agreement with DOE to give DFACS access to those educational records. And we eventually want to be able to have the juvenile court judges do the same. So when they're making placement decisions from the bench, they can have that educational information at their hands. So it is imperative that we try to ensure that a child, if they're performing well in a certain school, under certain teachers in a certain grade, that we try to maintain that stability. And even if we have to change, we don't want a situation where they're out of school for 7 days or 10 days. So it's very important that we're trying to work toward that in that regard. Also with regard to the statistics that are sobering with regard to older children as they age out of foster care, We have what we call an independent living program, which is targeted to those children who are 14 and over, to try to work with them through those years to prepare them for when they're no longer in state custody, so that through education or employment training or just basic life skills, they can have better outcomes than what we see today. So those are two major things we're trying to do in that area, and we'll try to continue.
Commissioner, talking about the independent living program, which thankfully Kara Steele Pitts does have and has entered an agreement with you, with the department to do that. But beyond that point, how much post-secondary tuition assistance is provided to help foster children enter and succeed in college?
I don't have that actual figure, but we can get it for you. I don't have it as I stand here.
Okay, and I'm gonna do my soapbox now, if with the indulgence of
Soapboxes are welcome.
Yeah, appreciate it
brief,
greatly.
For a brief time.
And of course, the commissioner knows how I feel about this, and I brought Kara Steele Pitts to the Senate. I still feel, and I'm going to continue to say that there is a place in our state for group homes, which Kara Steele Pitts is one, 100 beds, we're down to 15 children, and they've done a wonderful job for 125 years. This will be our 125th anniversary this year, and you all are all welcome to come to our anniversary. And there is a place for relatives, for them to be in homes with relatives. There's a place for them to be in settings that are not family-based, but I don't want us to throw out good programs like Kara Steele Pitts because we have had a change in the way some of the group homes have worked. You have to look at the good and continue to work with them because they are helping the children that we want to serve. And so, you know my soapbox. I just want to make sure that my compadres understand my passion for taking care of those children who need to have those services of a group home like Kara Steele Pitts. And it's not always the family, and it's not always a private foster home situation. So I thank you for your support with us and what you do, and we hope that the census at some point, it's a hard model. It's difficult for us to maintain. It's a very hard model with the amount of money that comes in to have all the social workers and to have everybody there, and it's been difficult, but we appreciate you working with us and having the independent living and doing what we do to try to continue to help our children.
Well, I appreciate that. You've heard me say before that we need the entire spectrum and continuum of providers and services. Of course, we would like for all children to be with their families and in their homes. There are circumstances where, for one reason or another, that's not possible, so facilities such as Kara Steele Pitts and our other providers across the spectrum from low to high acuity will, in some respects, I think, always be necessary. Thank you.
Last question, Representative Rogers.
Thank you, Mr. Chairman. Commissioner, I don't have a statement, but I do want to ask you this question. On your screen, on your slide dealing with the caseworkers you have and a number of cases you have pending, what is the definition of a case to DFACS?
In the child welfare arena, it is a family or a child to which you've been assigned as a result of allegation of abuse or neglect, or an investigation may be going on or something further down the road. For eligibility, it is an application for benefits, whether it be for food stamps, Medicaid, or TANF, that a particular worker is processing to either accept or deny and to move forward toward reimbursement.
So if I make a phone call to DFACS complaining about my friend sitting here, is that a case? How do y'all pre-screen? Do y'all do any pre-screening?
Yes. If it results
so
in...
a phone call is not a case?
Not at that point, no, sir.
Okay, but if I call in about a child or an adult, then a case file is put into place.
We will look into it, and if there's anything that we need to do as a result of that, whether it's to make a decision or not, then we will open a file on it.
Okay, next thing is, what is your turnover now on DFACS caseworkers? It used to be every 12 months, Have we gotten better at that, or are we still in that pattern?
I think we have. It may be as a result of the economy, because the employment market is not what it used to be. People may be staying. We're cognizant of the fact that as the economy gets better, we may lose people to higher paying positions. But our turnover rate, and I'm speaking off the top of my head, we'll get you the exact figure, but I believe it's around between 15 and 20% right now, which is, I think, a little lower than it has been. But we still have turnover in that area.
Can you tell me the percentage of turnover? Oh, you're going to give me that?
I'll get that for
Okay,
you.
thank
Yes,
you, sir.
Thank you.
Commissioner, that exhausts the questions. We appreciate your presentation and the work you all are doing, and I know it's important. And please know that the legislature stands ready to join with you. So
Thank you, Mr. Chair. I appreciate it. Thank you.
Next will be Community Health. Commissioner Cook. In writing. Submit your question in writing.
I got the judge with me.
It's 1:30, yeah. Two, hopefully, yeah. Might get you to operate that number 3 button there. This apparently, that overrides this. That's probably better over there. So you can leave it on for right now. That's mine, yeah. You can leave it on for right now, but when they start speaking, we probably turn it off or on accidentally. Say something. Headache. Hadn't seen him yet. There he is. Hey, David. How you doing? Commissioner. How you doing? We were just talking about you. Doorkeeper, if you can get those folks on in and the folks that are leaving on out and help us get that door closed, we'll get started. Well, why don't you suggest the doorkeeper?
I did, sir, but most of them have been here longer than they
I understand. I understand.
You're good to go, sir.
I don't want Schaefer was in the building yesterday, but I didn't see him in here. I could have sworn Balfour was here yesterday. Oh, sorry. I'm sorry. Storekeeper, if you can hurry up, try to get that door closed for us, we appreciate it. Ladies and gentlemen, if you'll take your seats. We've got a lot of visitors in here, and so everybody will be cooperative. We'll appreciate it. Commissioner, welcome. We're glad to see you and glad to have you. I know you've got important things to tell us, so the floor is yours.
Great. Thank you, Mr. Chairman. Chairman England, Chairman Hill, members of the Appropriation Committee. I really appreciate the opportunity to present to you today the Governor's proposed amended FY13 and the FY14 budget on behalf of the Department of Community Health. First, let me just say a word of congratulations to you on your election. I want you to know that at DCH, we're committed to working with you not only during this session but throughout the year, so don't hesitate to call on us if we can be of help to you. Those of you who were at the biennial session may have heard me talk about that old Chinese curse. That curse says, "May you live in interesting times." And ladies and gentlemen, I think we definitely live in interesting times, especially when it comes to health care. But I want you to know that I don't think of these interesting times or the challenges we face as a curse. I look at them as opportunities to explore how we might be able to change what we do and improve how we serve the citizens of Georgia. So we have no shortages of challenges and I guess no shortages of opportunities to work on those. I look forward to working with you on the numerous challenges that we have. As you probably know, DCH is Georgia's lead agency for healthcare planning, purchasing, and oversight. And I think that makes us ground zero for some of these budget challenges, not the least of which is our responsibility for administering and y'all's responsibility for funding some of the largest state programs in government, specifically two in our department, Medicaid and the State Health Benefit Plan. Currently, 1 in 4 Georgians receives health insurance through one of these two programs, either Medicaid or the State Health Benefit Plan. The department also has a couple other program areas, including health facility regulation, where we license and inspect over 7,000 healthcare facilities, nursing homes, hospitals, and the like. And we're also the lead agency for health information technology. We have several major initiatives going on in that area. We completed the stand-up of a new Medicaid member information system, and we're working on a state eligibility information system between departments, DCH, DHS, and the Department of Public Health. Total funding for the Department of Community Health, total funding meaning federal funds and other funds, is about $11.9 billion. I thought it might be interesting just to provide a little bit of a context, because I think this is an issue we all face, about healthcare costs and how they impact budgets, both nationally and throughout the state and in the private sector. And I was looking at the Congressional Budget Office webpage the other day, and I thought the quote from the Congressional Budget Office was a very good quote. Let me just take a minute to read it to you. Congressional Budget Office just last week said growth in spending on health care programs is one of the central fiscal challenges facing the federal government. Health care spending per person has grown faster than the nation's economic output per person by about 1.5 percentage points per year on average over the last few decades. This rapid growth poses a challenge for federal health care programs such as Medicare and Medicaid, and also for state and local governments and for the private sector. So I think that includes just about everybody. In short, I think budgets of governments at the state level, at the national level, at the local level, and private sectors are all impacted by the growth in health care. So I wanted to give you a few numbers just to put it in perspective on a national basis. You can see from this slide that healthcare spending has grown from 12.5% of GDP in 1990 to about 18% of GDP today. Just in the last decade, healthcare spending as a percentage of GDP has grown by about 30%, from 13% of GDP in 2000, as I've mentioned, to almost 18% in 2011. So obviously, these trends are impacting Georgia. I would say the good news is that I think Georgia is doing a better job than most states, and clearly a much better job than the federal government in terms of how we're managing health care costs. I've heard a couple speakers previous to me talk about the situation at the federal level. Clearly, that's one that has to be addressed. Will have some impact on the state, depending on what they do. But the deficit and the debt, clearly to be dealt with long range, has to deal with entitlement programs, one of which will be Medicaid. So we're going to be paying very close attention to that. I'd like to also mention a fundamental point about these two large health plans that we administer at DCH, both Medicaid and the State Health Benefit Plan. They're an important part of the state budget, as I mentioned, about almost $12 billion in total funds. And, well, the State Health Benefit Plan and Medicaid are similar. They're large insurance payers. They provide health insurance. We pay a large number of claims every day. We require reserves, frankly, to cover unexpected variances in experience. But it's really important to note that while we've got these two health plans, they require two very different management approaches. Medicaid is an entitlement program. I would call it cumbersome. It's very restrictive. There are a number of limited options that we have, and there's really an absence of member accountability or any consumerism models within that. It is so stringent. By the way, I just had these facts checked the other day. I've been in office for 24 months, and in that time we have applied for 31 waivers or exceptions to our amendments to our program. So more than one a month on an ongoing basis. So it's a very restrictive program. On the other hand, the State Health Benefit Plan allows us much more opportunity and flexibility to manage those costs. 2 years ago, we were facing a deficit in the State Health Benefit Plan of $815 million. We had no reserves because they had been spent down during the Great Recession, and we reduced that deficit from $815 million down to by $753 million. Or in other words, we reduced that deficit by 92%. So we did this through a number of measures, plan design changes, and a number of things that we can get into, if you like, into the specifics. But we also did it with an eye towards the future. We created the largest wellness plan in the country. And we also took a look at our long-term liabilities, called OPEB liabilities, and thanks to the leadership of many in this room and others, we made some structural changes to the State Health Benefit Plan that reduced our 30-year liability by $11 billion. It went from $62 billion down to $51 billion by tying the amount of the subsidy a retired person can get to the number of years that they work. So we've made some good progress in the State Health Benefit Plan, but we have many opportunities and challenges ahead on that. Let me give you a brief overview of the Department of Community Health and its budget. This is a pie chart. And overall, as I've mentioned, total funds, this is federal funds. Big piece of this is Medicaid. Medicaid, we get about $2 in federal funds for every $1 in state funds. This includes all the funds together. So about a $12 billion budget. Medicaid accounts for 2/3 of that budget with total funds of about $7.8 billion. Medicaid is essentially divided into two programs, which you can see on the pie chart there. The red pie is the ABD program, which age blind and disabled, which comprises about 38% of the population. and that is about 38% of the budget, and that is about $4.5 billion in total spending. Low-income Medicaid comprises about 28% of the budget, and that total is about $3.3 billion. Peach Care, which is a shadow or parallel health provision with Medicaid, consumes about only 3% of the budget, or just $330 million. The other major component is the state health benefit plan, which is composed of other funds. They're not state funds. They're premiums that are paid and employers paid and that kind of thing. That totals about $3 billion per year and represents about 1/4 of our budget. So let's turn to the largest program within our budget, Medicaid. I wanted to put together some information to give you a little bit of an idea about the trends that we're facing at the national level, so we can compare how Georgia is doing with regard to Medicaid. And when you look at the history of Medicaid, it was established in 1966. Medicaid is one of those federal programs that's grown and grown over time. We have expanded the program to cover a wider range of services, make it available to a larger group of individuals at higher income levels. So in 1966, when the program was launched, you could see that we had about 4 million enrollees. It's about 2% of the population. It cost less than $1 billion, and it was less than 0.5% of GDP. You can see in 2010 that has grown to about 54 million Americans, which is about 17% of the population. Again, these are federal figures, national figures. Medicaid in 2010 cost the federal government about $401 billion, or was about 2.7% of our gross domestic product. In 2020, you can see a significant ramp up just in 10 years, where the Congressional Budget Office, and these numbers are post the U.S. Supreme Court decision, expects Medicaid to grow to 85 million Americans, covering about 1 in 4 Americans, 26%, with a total cost of more than double, $871 billion, and consuming about 3.7% of the GDP. So that's the national picture. How does Georgia compare to that national picture? I didn't go way back on this, but I took some 3 periods of time that I thought would give you an idea of the general trend. You can see in 2000 that we had just under 1 million enrollees, which was about 11-12% of the state population. We had about 1.3 billion, 1.4 billion in state funds spent on that program, and that was about 10% of state revenues. In 2009, we had that had grown to about 1.4 million people, up to about 15% of the state's population, with state funds growing to 2.4 billion, or consuming about 15.3% of state revenues. You can see, without any expansion of the Medicaid program, our projections are we will grow to about 1.8 million people by 2019. We'll be right at about the same percentage of the population. We will see healthcare expenditures grow to about 3.8 billion, and will remain what it currently is, which is about 17.1% of the growth, assuming that our Medicaid growth grows at the current pace and the economy grows at the current pace, which is, in rough terms, about 4%. So who are the people that make up Medicaid? Medicaid, as I mentioned today, this is FY12. We had about 1.5 million people in Medicaid, and about 200,000 in Peach Care for Kids, for about 1.7 million people in that program. You can see that about 1 in 5 Georgians, 17.6%, are covered by Medicaid. But we have many more children covered in Medicaid than the adult population. We've got 41% of the children in the state are covered by Medicaid or Peach Care. So how much does it cost? We talked about that a little bit. In FY12, state, federal, and other source funds was about $8.1 billion in the Medicaid program, $328 million, as I mentioned, in Peach Care. The average spend per day, this is a good figure to put it in perspective, the average spend per day is about $31 million. That's for every business day. We pay about 200,000 claims per day, and nearly 60% of all children in Georgia are born and are covered under the Medicaid program. Their births are covered under Medicaid. And as I mentioned, you can see the little slide in the graph in the bottom right-hand corner. Medicaid and Peach Care represent about 17% of the budget, and you can see that going back for several years. I mentioned the rate of growth. This is, excuse me, this chart represents the rate of growth in Georgia versus Medicaid at the national level. And since 2010, our rate of growth, of course, I think we're starting from a lower base, but our rate of growth has really tracked along the rate of growth at the federal level for the last 2 or 3 years. Our rate of growth in FY12 was 6.6%. Nationally, it was 7%. You can see, I talked about starting from a little lower base. This is a figure that, or a table that shows the amount of spending per member per year in the Medicaid program compared to some of the other states in the Southeast. Again, Georgia is at the lower end of the schedule, spending about $5,300 per member per year, and you can see it goes up from there with our other neighbors in the Southeast. We are the lowest in the Southeast. Alabama, which is the next closest, spends about 18.5% per member per year more than Georgia. North Carolina, which is the highest in the Southeast, spends about 51% more per member per year than does the state of Georgia. I always find this slide interesting to talk about the difference between our two programs in Medicaid, the age-blind and disabled, and the low-income Medicaid. Age-blind and disabled is reflected by the red bar, and the low-income is the blue bar. And you can see that the age-blind and disabled population comprises about 29% of those enrolled in Medicaid, but consumes about 58% of the money spent in that particular program. I think there are a lot of reasons for that, a lot of which makes sense. You have in the age-blind and disabled a population that is disabled, elderly, they need more care, they need more services, and I think it's intuitive that you'd spend more money based on that population. There's also a difference in how we manage these programs as well. The low-income Medicaid program is in a managed care environment. We contract with 3 CMO entities that provide managed care coverage, and we pay a capitated rate to those 3 CMOs to cover the low-income Medicaid population. In terms of managing costs and the budget in Medicaid, there are 4 areas that you can look at in any health program to look at how you deal with managing costs. First is eligibility. That includes everyone who's receiving or eligible to receive benefits, what income levels are covered, etc. In Medicaid, there is very little, if any, room to reduce eligibility. Maintenance of effort requirements at the federal level prevent any adjustment for that. Scope of benefits is pretty much in the same category. Scope of benefits are those types of services that are covered, and there are federal regulations in place now that do not allow much of a change in scope of benefits, although there are a few areas that we'll talk about in a minute. Utilization probably provides the greatest opportunity in terms of some flexibility from the federal government, which is utilization is how often those services are used. You can see, or we'll go through some of our initiatives regarding that as we attempt to achieve the 3% and 5% reductions that were called for by the governor a few months ago. And price is the last category. Price is what I would call either what you pay, the rates that you pay, or the reimbursement methodologies that calculate those rates. Those are something that as we manage the program we looked at as last resorts. We did not want to cut Medicaid provider payment rates. You'll see in the governor's budget there is a small reduction there, but we went through very thoroughly each of the other categories in order to try to avoid that, so we'll talk about that in just a minute. There's also a very important piece of the governor's budget, which is the provider payment agreement, which expires at the end of FY13. The provider payment agreement allows us to continue the Medicaid program at its current level. It does not fill any funding shortfalls that we have or currently experience in Medicaid. In FY13, you can see from the chart here that we project that we will collect from this fee about $234 million. Those fees and that money is deposited into the Indigent Care Trust Fund. We then use those trust fund monies to pay expenses and draw down federal funds, and with that we combine that money with the federal money. We generate about $685 million. So of that $685 million, 251 are paid back to the hospital industry, making it whole, and about the other $434 million is used to support Medicaid generally. Now, assuming reauthorization of the Act in FY14, we project the revenue from the provider payment agreement to be about $241 million from the fee. The payout to the hospitals would be about $258 million, generating about $450 million in additional funds to be used across the Medicaid program. There's another feature of the Affordable Care Act. There are several actually, but one of those features is this year we are required by the federal government under the Affordable Care Act to pay primary care physicians at 100% of the Medicare payment rate. That is paid for with 100% federal funds, and that's a 2-year provision. You can see there the amount. I think these are total funds, $75 million. Total funds is $75 million and $150 million in FY14. Again, those are funds totally covered by the federal government. Now, you may have heard some discussion. I've heard some questions about it. When this is supposed to be in effect, January 1st, 2013. It is not in effect right now because we didn't get the rules and regulations as to who was a primary care provider, what services would be covered until late November. We will be making those adjustments in our computer system. I think we'll be ready for that in the spring, and we will make those payments retroactive back to July 1st. So we expect that to roll out around springtime. The other major piece that may be somewhat confusing, and let me address it right now, in the budget document they call for a transfer of about $2.4 billion in one area to a new Medicaid program. There are 2 program areas in Medicaid, as I've talked about, the age blind and disabled and the low-income Medicaid. And what we're asking for in the budget is just to combine those programs, as most other states do, as a Medicaid program. And this is going to give us some additional flexibility in managing some of the cash flow and the billing that comes through between the ABD and the low-income Medicaid. So it doesn't change the budget, it doesn't change the dollar figures, it just changes the program area. We intend to continue to keep age blind and disabled as sub-programs so that we can continue to track those. I think it's important to track those programs separately, but what the structural change would do in the budget would give us the ability to a little bit more flexibility within managing the Medicaid budget. So with that, let me get into some of the specifics in the Medicaid budget and the budget document. And I don't think ours totally coincide with maybe the tracking sheet that you have. I'm going to ask you to take a look at that, the slide here, because I tried to put these in terms of categories where they make maybe a little bit more sense. Item number 1 is our projection increase for growth in Medicaid. As you can see really at the top, there are bases for this is ABD and low-income Medicaid. This is ABD. This is combined, I'm sorry. $2.5 billion. We project an increase of $211 million in 13 and $217 million in FY14. Item number 2 relates to implementation of something I believe is already in effect, which is following the Medicare, and I think we were directed by the federal government to do this, eliminate hospital reimbursements for preventable admissions and readmissions for savings of about $1.4 million in 13 and $2.8 million in 14. Item number 3 is reflect savings through better enforcement of level of care qualifications for long-term care and home and community-based services. We project that to save about $3.5 million in 13 and about $7.2 million in FY14. Item number 4, we reflect savings from restricting the number of narcotic prescriptions to 6 per month. Doesn't save a lot of money, but a good policy decision there, I think. Item number 5 is to, after we got our MMIS system up and running, we're very aggressively finalizing our hospital cost settlement reports. By doing this more rapidly than projected, we're saving about $20 million in FY13. Item number 6 reflects savings from the drugs that we have on the specialty pharmacy list and getting a little better discount, save $320,000 to $600,000 on item number 6. And item number 7, we reflect savings from modeling, again, the Medicare program, eliminating the CPT codes, which replaced, or eliminating the consultation codes within the CPT terminology. Again, that saves about $3 million in FY13 and about $4.5 million in FY14. Item number 8 is a restoration of funds from the budget bill last year. We included about $4 million in that particular fund, which was higher than what we could realize in ramping up some of our fraud and abuse efforts. We had projected about 2 to 1 return on investment in that area. The budget actually ended up at 4 to 1, and we weren't able to achieve that 4 to 1 number, so we're asking that $4 million be reinstituted. Number 9 is the nursing home provider fee. You've heard talk about that. We're adding an additional $10 million of revenue in the nursing home provider fee to help nursing homes with their payment rates. Item number 10 is our current revised projection on hospital provider payment agreement. Item number 11 just moves some tobacco funds. Item number 12 increases funds to offset unrealized reserves. In FY12, we have projected that there would be about $10 or $11 million in reserves, which is typical from last year, or from many years preceding us. Last year, we did not end with a reserve, and we're asking that $10.9 million be restored to the base. Item number 13 is a change in policy. This is something that has been championed by the Commissioner of Public Health and has a lot of data about carrying babies to term and 39 weeks and how that can impact education and the development of the child. So we're reinforcing that by eliminating reimbursements for elective inductions prior to the 39th week. So there'll be small savings in funding for that as well. Item number 14, our FMAP rate. We got those numbers since we met last year. The new FMAP rate, federal matching rate, is a little bit more favorable to us than we anticipated last year. That saves us about $10 million in FY14. Item number 15 reflects savings through case and disease management programs, saving about $2.6 million in FY14. Number 16 is the provider rate cut that I had mentioned. It's 0.75% for selected groups of providers. The hospitals are not included in that. Primary care is not included because their payment rates are dictated by the Affordable Care Act for the next 2 years. Federally qualified health centers and others that have specific federal regulation related to that. As you can see, that cut goes into effect in FY14, and the savings there are just under $13 million. Item number 17 increase the, we just through normal growth in expenses paid to hospitals, we anticipate that we'll collect about $6 million more in the provider payment agreement, and you can see that those savings there, or that expense there, that would be paid out rather. Number 18 reflects savings from the new Medicare base methodology. This is the APC grouper, where we changed the DRG methodology that we expect to roll out in FY14 for a savings of $33 million. And item number 19 was a change in the federal law where we can get supplemental drug rebates on managed care companies, and we're implementing that for a savings of about $1.2 million. Item number 20 is an interesting one. People talk a lot about the optional or expansion into the Medicaid program. There was a mandatory expansion into the Medicaid program too. For those children that are between 100% of the federal poverty level and 133% of the federal poverty level are mandated to be covered under the Affordable Care Act in any Medicaid program that will be implemented in FY14, and you can see the associated costs with that, about $13.3 million. So the net change in FY13 is $207 and $181 million in 14, giving us a revised base of 2.7 in 13 and a 2.6 in 14. And item number 21 is that shifting to a one Medicaid budget program in the budget rather than splitting it into ABD and low-income Medicaid. Next, let me turn to the smaller program, Peach Care for Kids. The benefits and the administration of that is essentially the same. Our growth figure for FY13 is seen on line number 1 at $9 million and about $7 million for FY14. I'm not going to go through these. They're essentially the same as the others, but let me turn to item 9, which is on the next page. Here you can see the offset of that movement from Peach Care for Kids into the Medicaid program. We talked about those 50,000 children that are now in the new mandatory Medicaid program. That cost, we'll have additional expenses in Medicaid of about $13 million, but those people are mostly going to be moving from the CHIP program into Medicaid. So here you see the resulting offset. So we'll be saving money in Peach Care with that movement of people into Medicaid. Now there's one caveat with that. I think there's at least 1 year guidance on this. The federal matching rate for the Peach Care program is more favorable than the Medicaid program. This assumes that they continue to keep the more favorable federal match for this new Medicaid population that's moving in. I'm not sure, and I don't think that will last more than a year or two. That will probably just come in under the old match, and then we'll have a little bit more of an increase in costs related to that. That covers Medicaid and Peach Care. The other items in the budget really are the same as in the Medicaid program. Let me turn to the State Health Benefit Plan, give you a few facts on that. We have currently 643,000 Georgians that are covered with State Health Benefit Plan. We've got 227,000 active employees. You can see the number of retired people covered and the number of dependents. It's interesting, in FY 2007, we had a 3-to-1 active employee ratio for every retiree. In FY 13, it's down to 2-to-1 active employee for every retiree. So similar to what we're seeing at the national level with Medicare and Social Security, we have fewer workers supporting a growing, retiring, and aging population. Our funding, as I've mentioned earlier, is about $3 billion in the State Health Benefit Plan. Those are all other funds. They're not state funds. We generate those through premiums and employer contributions, and they're considered the other fund category. On an average business day in the State Health Benefit Plan, we pay out about $11 million per day, and a similar number of claims, about 200,000 claims per day. Who is an SHBP member? They are all over the board. We have all kinds of different people that belong to the state health benefit plan. In fact, we have 875 different employer groups that we manage. We have a payroll location in each one of these 875 payroll locations, and you can see they cover state agencies to public school districts to county health departments, DFACs, centers, technical colleges, libraries, etc. So a very diverse population. I think it's important to talk about fundamentally with regard to the budget, the state health benefit plan. It's important to understand that there are really three plans. We manage them as one, but there are three separate plans. One is the state employees plan, as you can see on the far left. The middle one is the teachers plan, and the third one is what we call non-certificated or the locally funded school personnel fund, bus drivers and cafeteria workers and others. Now, you can see from this chart there's a surplus and deficit related to each one of those reflected in the green bar. And if you can see on the slide here, the state employees plan generated a surplus of about $216 million this year. Teachers about $174 million, and the item we've been struggling with over the last several years is making up the shortfall in funding in the non-certificated plan. We were able to reduce that, frankly, this last couple years. Currently, that stands at about $452 million. This next graph drills down into that last point a little bit more. You can see from the slide shows the historical and the current makeup of revenue for the non-cert plan compared to their expenses. We used to have a state contribution through the Department of Education that helped fund that gap. You can see that in the green part of the bar there. That green bar started being reduced with the Great Recession and was totally eliminated in FY11. As a result, we worked with the legislature and implemented a 3-year plan to increase the employer contributions $150 per member per month to help make up that difference. And you can see from the red bar there's a significant increase in the amount of money that locals are now paying for on this particular plan. At the end of the 3-year period, you can see we're still not going to achieve budget neutrality on that. So while the local systems have been hit hard in terms of the raise in the employer contribution there, we are still, as a fund in general, not securing enough either premiums, which are the employee contributions in the blue, or employer contributions to make up that difference. I would hasten to note that all the employees are paying the same amount as all the other employees, so which is about, we try to make it about 25% of the total cost. So the employee should pay about 25%, the employer should pay about 75%. In this particular plan, we have a shortfall occurring within the employer portion of that. Now, some of our change in demographics, which have been caused by a variety of factors, including a reduction in the number of teachers, impact the teacher fund. This one I wanted to give you a heads up on impacts drills down into that teacher plan a little bit. You recall a couple of slides ago I noted that we had a surplus in the teachers plan of about $170 million. The blue bars here represent the surplus or deficit in the teacher plan, and you can see that that surplus we're projecting is continuing to go down, and that by 2015 we may have a deficit situation. You'll see some items that we'll talk about in the governor's budget to begin to address that. You can see the changes or how that would look with the changes that are made with regard to the governor's recommendation in the budget. So let's turn to the budget. These are items in the budget that talk about putting the state health benefit plan on sound financial footing. Item number 1 is that non-cert 150 member per month increase in FY11. You can see that'll generate about $107 million more. Item number 2 is the increase for the employer contribution rate for teachers. That's about a $25 per member per month increase. Goes from $912 to $937, and that is slated to begin in March of 2013. That generates about $7.4 million. I might add that the employer contribution for teachers has not been raised since 2008. Item number 3 also relates to the teachers, and that is the FY14 increase. There's an additional $8, 25 plus 8, $8.14. That would raise about $37 million, $38 million total. Item number 4 relates to state agencies and state workers. Increase the employer share of the state health benefit plan from 29.7% to 30.2% effective January 2013. That's 0.5%, and that generates about $6 million. And item number 5 for FY14 would increase that by 1%, generating $26 million in FY14. Now, I mentioned that in addition to these items that we have created the largest wellness plan in the country. We're very proud of that. We've got 45% of people in the state health benefit plan who are enrolled in our wellness plan for calendar year 13. Those that were in the plan last year promised to do 2 things. They promised to have their biometric screening done, and they promised to go online and take a health care assessment. We had a good number of people that were able to do that, and we've got some interesting data I want to share with you on those people that were actually able to do that. We did hear some concerns about not knowing what to do and that kind of thing, so we've been pretty generous in terms of our appeals process, and if anybody made an effort to get there, we've been pretty generous in terms of getting people into that plan. But we found that rather than having our incentives based on a promise and then giving the incentive, we think it's going to be better to change that based on action. So at the end of the year, people will get a $240 additional supplement that they can use towards their health care if they complete the promises. So it's actually going from a promise-based situation to an actual active-based system. So if you complete it, then you earn the money rather than getting the money based on the promise. So that's a significant change in the plan going forward. I wanted to take just a minute to give you an idea of where we're headed with the wellness plan. Our first year was just to get an idea of what is the status of the health of our state employees and the people involved in the state health benefit plan. As you can see here, we had, this is about, what, 50%? About 50% of the population in the wellness plan, and here's the ones that completed the biometric screening and the data, collective data regarding that. You can see that 54% of the people enrolled in the state health benefit plan had a blood pressure that was greater than 140/90, a little bit out of range there. The body mass index, the one at the bottom, you can see that 74% are outside the body mass index, probably your commissioner included in that one too. But we can, with this data now and knowing who the people are, we can now begin to target people with specific plans and specific opportunities to help them engage in taking better health, making better decisions about diet, making better decisions about exercise, and now we've got at least a benchmark, and we can have something that we can try to move the needle on. So that'll be interesting with this population going forward. We also have an initiative related to childhood obesity. The governor's initiative there is to reduce childhood obesity. Department of Public Health is the lead on that. We have a couple of changes in the budget that go to fund those initiatives. So if you turn to the budget, You can see item number 6 reflects our continued implementation of the engagement plan that I just described. That will cost about $7 million in 13 and about $12 million in 14. That relates primarily to getting people engaged on a very specific and targeted level that I just talked about. Item number 7 reflects an increase of $4 million in 13 and $8 million in 14 to provide additional coverage for doctor's visits for children who are obese. We're expanding that coverage to 4 doctor visits, and then we're also expanding coverage to include 4 visits to a dietitian so that people can work on those healthy habits. So we've expanded coverage to initiate that, those initiatives. Responsibly managing the state health benefit plan. This is a graph that you can see illustrates that the plan design changes that we talked about over the last 5 years in the state health benefit plan, that our expense trend was about 3% lower than the national expense trend. Our plan expenses grew about 5.1% over that period compared to a national trend of about 8.4%. That equates to, over that 5-year period, about $1.3 billion in savings. So, responsibly managing the state health benefit plan, we have a few plan design changes we'll begin implementing. We are removing the prior authorization for ADHD drugs. That saves a little bit of money in administrative expenses there. Item number 9 reflects savings from implementing a step therapy program. I think Cigna currently does not have that, but we're moving it to the same step therapy program that United Healthcare has. So it'll be making those two benefits aligned. Item number 10 reflects savings from negotiating rates with hospital networks. We believe we can save a little bit of money there. $5 and $6 million respectively. Item number 11 reflects savings by moving to a uniform prescription drug list. Currently, we on the HRA plan, we'll move to a little bit tighter preferred drug list, which is the same preferred drug list used in the HMO and the high deductible health plan. We also had a change in premiums this last year. I think one of the big changes I want to note for you is a change in spousal subsidy. One of the things that we looked at, first thing we addressed, I talked about dealing with the subsidy, if you will, for the non-certificated plan where we had that deficit. The next big subsidy that really stuck out at me was the fact that we're not really covering employees. We're not really covering 25 to 30% of what it costs to cover a spouse. So we're starting to move towards getting that coverage up to that level. We had a program that was a little bit different. We said that if your spouse works and has coverage available to them, and you let us know that, and you tell us that you want to go on to the state health benefit plan, then you pay an extra $50 per member per month premium. That was a promise-based system. You could question how effective that was. We did away with that, and instead what we're trying to do is just change premiums to get them to where we cover employee covers about 25% of what it costs to cover the spouse. So that was kind of all over the board. We're trying to equalize and rebalance that out. You'll see some premiums went up, but none of them went up more than $90. Plus you had the $50 reduction in the spousal payment. So we're rebalancing that, and you'll see some fluctuation in that. On an aggregate, we had about a 7.5% increase in premiums, and in addition to that, there was a 2% increase in premiums that relate to the new mandates that come into effect under the Affordable Care Act this year, which requires some of the women's health and preventive services to be covered at 100%. And this is the first year that a fee will be imposed. It's a $1 per member per year fee. So for us, it's $650,000 to pay to the federal government to implement that program called Clinical Effectiveness Research Program. So this year it's $1 per member per year. I think next year it's $2. So you'll see that that was one of the increases that we built into the premiums. Thought it'd be interesting to take a look at, if you can go back one slide there, since the implementation of the Affordable Care Act, how much have premiums gone up as a result of that? We've kept track of that, and we've highlighted that in each budget year. So it's been 3 years now, and we see a total of about 14.3% accumulation on that over those 3 years. You can see 6.1% in 11, 6.2% in 12, and this year a 2% increase. So fostering a culture of personal responsibility, we reflect savings by implementing some of the plan design changes that we talked about. That generates $66 million in FY13 and $160 million in FY14. You can see the increase in the employee contributions for spousal coverage generates about $36 million in 13 and about $119 million in FY14. You can see in item number 14 the 2% increase related to the Affordable Care Act. That generates about $6.8 million in 13 and $14 million in FY14, and the 7.5% increase on average for premiums is about $6.4 million in 13 and about $12 million in FY14. And then one other thing, we had a differential in the administrative costs between the two health plans we have, Cigna and United. United's plan was a little bit more expensive in terms of administrative costs. We thought we would break that out. People that choose United, it'll be transparent that they're paying an additional $7 per member per month to cover the additional administrative costs associated with United Healthcare. So you can choose either one, and if you choose the United plan, you'll be paying just a little bit more due to those higher administrative costs. Item number 17 reflects our updated revenue and expense projections. As you can see, in 13 it's $74 million and $64 million in 14, for a net change of $81 million in 13 and $244 million in FY14. And when you take our revenue less expenses, you see that we end 13 with about a $19.8 million revenue, which is used to offset the $18 million deficit that we had in FY12, which leaves us a total reserve of about $1.4 million, which is about 2 hours of spend in the state health benefit plan. You can see this is budgeted very closely, and Medicaid is essentially the same. One of the concerns I have is that we need to have enough flexibility in terms of how we're budgeted to make sure we can cover fluctuations in expenses. This year we had the flu, a big flu season. I think when I was standing here last year, I couldn't anticipate that we had that flu season, but these things do occur and we do have some fluctuation, so we would ask you to keep that in mind going forward. How are we doing on time? I can just make one last brief comment on health facility regulation. Okay. I just wanted to point out the Georgia Map to Care, which is, I think, a great example of government doing more with less. And we took the current Google Map technology. It actually came out of a tabletop exercise on disaster preparedness we did with the governor. And we wanted to know, where are our facilities, what is their capacity? If there's a hurricane and we have to move people out of Savannah, where are we going to move them to? Is there additional bed capacity somewhere? So we went on Google Maps, we created this technology, and it's been great. We use it for our own internal uses. We can use it in a disaster, but we've also rolled it out to consumers. We've got all 7,000, every facility we license is included on the map. You can go out and you can do a search by area or by type of facility or several things, part of the state, whatever you want to search by, and find different facilities. And you can click on that facility. You can see a street view of it. You can see any administrative actions we've taken, any deficiencies we've reported. You have access to all of our data in terms of inspections and licensing documentation. You can do that street view, which you can get a virtual tour around the facility, see what the neighborhood looks like, etc. But importantly for us, this has been something where we've saved some money. We have used this also in our own private database. We've got all the home addresses of our 250 or so surveyors, and we're able to use those to better put together teams and manage their mileage and how they go about doing surveys. And with that, we've been able to reduce the number of workforce that we have, at the same time improving the number of inspections that we do, so that now we're current with the federal mandates in terms of how often facilities should be inspected. I would note that Google has seen this now. They're very interested in this product. They want to talk to us about it, and they view it as a great example of what state governments can do with their mapping technology. So with that, Mr. Chairman, I'll stop and answer any questions.
I don't know how closely you had it timed, but you used up all of your time plus 1 minute, actually, Commissioner, whether it was by design or not. But there are some questions. I tell you what we're going to do, ladies and gentlemen. We're going to take 10 minutes for questions, and we'll see how far we get. So at about 11:25 or 26, we're going to stop wherever we are. So let's go ahead and start. And the first question is Representative Gardner.
Thank you very much, Mr. Chairman. I'm concerned about the cash reserves in Medicaid, and I was trying to understand what it meant on your handout, page 11, number 12. I mean, are we working toward creating some reserves in Medicaid?
Oh, we are. And one of the things that I think is important to do is, I think traditionally Medicaid has been not fully funded in the annual budget, and we come back in the amended budget and put that money back in. In FY13, the amount that is in the governor's budget indicates a filling of that hole, $207 million, I believe.
And that provides adequate reserves for Medicaid?
That fills the hole, and it meets our budgeted projections.
I mean, is that enough to maintain a fiscally sound insurance program?
Well, I mean, it's always good to have more reserves, and I think what the state is doing is trying to build back those reserves as we climb out of the Great Recession here. We feel comfortable with this number, but it is also a number that's, it's not where we used to be, where we had $300 or $400 million in reserves.
I am concerned about it.
Senator C.
Thank you, Mr. Chairman. Commissioner, how long has the department and preceding agencies been managing health care here in Georgia?
How long has preceding agencies been managing health care?
The department and preceding agencies, or.
Well, I think since the creation of those departments, at least since the 60s.
Okay. And what is the status of the department overhaul to the Medicaid eligibility system, and what's the timeline for implementing the new system?
I think you're referring to the electronic eligibility system,
yes.
Which is a program Commissioner Reese may have mentioned. This is a program. It's an IT project. It's in fact y'all approved a bond on this for $10 million. It's 10 federal matching, $90 of federal money to $10 of state money that we're generating through the sale of that bond, which was successful. And it is a IT project where we're looking at being able to allow any member of the public to go in on the website and find out if they are eligible for Medicaid. Medicaid is the first one out. Whether they're eligible for Medicaid. If they're not, they theoretically can be transferred to the exchange if and when there's an exchange that's brought up. This is all envisioned under the Affordable Care Act. One piece of that is this eligibility function. So it's a massive IT project that is being worked on in coordination with our department, Human Services, and then also Public Health, because eventually we want to bring TANF eligibility on that. A lot of the same people that are on Medicaid also are eligible for TANF that may also be eligible for WIC down the road.
Senator, I've got 8 more questions, and we're not going to get to all of them. Since you got them written down, why don't you submit them in writing too? Representative Chanel.
Thank you, Mr. Chairman. Commissioner, I draw your attention to slides 16 and 17 on page 9 of your handout, but it has to do with the 2013 hospital provider fee and the 2014 provider fee, which, as you know, is a mechanism in which we draw down federal funds. My understanding is it's 49 states that do something similar. Alaska doesn't because they pay people to move there. But my question to you, it appears to me that in 2014, net additional money coming in is almost $500 million in 14 and a similar amount in 13. If this act is not reauthorized, it appears to me that there's a $500 million hole in the budget as it relates to this item, and it's going to have to, we, the General Assembly, will have to figure out a way within this budget document to come up with that money, or reduce provider rates in that amount. Is that, am I reading that right?
You are, sir. The governor included these funds in the budget, assuming reauthorization of that act by the General Assembly. And I went through the eligibility and utilization and scope of benefits. This is in the Medicaid program, so our opportunities to address a $550 million shortfall, if that were not passed, would be pretty much limited to addressing it through provider payment rates, which I think could be significant. It's about, as you mentioned, about $500 million.
Senator Tate.
Thank you, Mr. Chair. Commissioner, thank you for your presentation. I have a couple of questions, which I'm going to just give them to you, and you can respond to whichever one you want and get the rest of them to me later. Okay. One by one of my caucus members who it's important to him, so I'm going to ask that one first. It has to do with your community service boards, and the question had to do with how much do you collect in health benefit plan money in which employees have health insurance coverage through spouses and do not utilize the state health plan. And I mean, he's saying that with community service boards, they have to still pay even though they get coverage from their spouses. And so his bandwagon becomes how much is going into and what's happening to that money that they have to pay. So if you don't answer that, I just want to make sure that was on the record. The next question, how many uninsured persons are there in Georgia? My next question is, what are the annual costs to Georgia for uncompensated care due to uninsured persons? And my last question, can you explain the details of the level of care savings that appear in the budget? Will better enforcement of level of care determinations reduce the number of people getting served? And if so, what is the estimated number of people who will no longer receive services? And those are my 4 questions, and you can take any one of the 4 and get me the answers to the rest of them. I appreciate it. Okay.
Well, there's, and rather than some of those numbers I don't have right off the tip of my tongue, so I'll be glad to get you those specifically in writing. One of the things that we are doing in the budget, and I think this relates to your last question, if I understood it right, is to do a level of review for people entering home and community-based services. Now, one of the things that under our federal waiver, the federal waiver that we have, which is the SOURCE program and the ICWP program, requires that there be a cap. And any waiver under Medicaid also requires that it be cost neutral, that it can't cost more money. So we implemented that cap last year. Frankly, we weren't complying with that cap. One of the ways that we can deal with that cap is to take a closer look at who is eligible and going into those services. We found a large number, about 50% of the people, a year after they were in that services, were no longer eligible for nursing home level of care. They have been moved out of that program now, generating savings. I think it's about it's in the budget there, about $8 million a year. The two effects of that, I have three effects. One is we're providing services to those people that are really eligible. That's number one, and honing in on that a lot better than we had been. Number two, by doing that, we're creating more slots that for people that are on the waiting list that are needing to be in that. So we're saving some money, and we're doing this as a mechanism to move people off the waiting list.
Representative Dr. Watson.
Thank you, Mr. Chairman. It was an excellent presentation there, Commissioner Cook. I just want to draw your attention to page 17, slide 33. It looks like the per member per month is about $912. That's per month. So that's going to be about $10,944 if I added up correctly per year. The concern I have is that reportedly these are healthy people below age 65, not all, but most. And if Medicare payment for over age 65 on average is somewhere between $9,000 and $10,000 a year, why are the state health benefit plan members costing the state of Georgia more money? Did I make myself clear?
Yes, sir. That's a good question. I guess I'd want to sit down with you and look at some specific numbers. We did look at Georgia numbers in terms of both premiums and costs that employees pay, and they are right on par with what is being paid in the private sector in Georgia. And I have those figures here in a chart. I'd be glad to share with you. I don't believe that we're paying more than the average Georgian out there. Now, I think healthcare costs may be a little bit higher in the South than maybe other parts of the country, but I'd be glad to go through that data with you.
Ladies and gentlemen, I apologize, but we've exhausted 10 minutes past the time, a little over 10 minutes past the time, and
I'm sorry.
I would suggest committee members, as members of the Appropriations Committee, you can at any time during the year submit questions to the Commissioner. I'm sure he'd be glad if you want to submit them in advance of his appearance here or in advance of subcommittee appearances. You certainly have that right. I suggest that that's a good thing to do. So, I apologize. This is a very vital area, and I'm sure it has a lot of wide interest, and we maybe should have allotted a little more time, but we're on the schedule. We've just got to get through by lunchtime in order to have the block grant hearing. So, Commissioner, I appreciate very much you being here today, and you've got a really tough job to do, and a lot of the things that control you are out of your control, and we appreciate what you're doing. Sure.
Thank you, Mr. Chairman. Thank you.
Thank you very much. Ladies and gentlemen, we'll move right into public health. If Dr. Fitzgerald will come on up. Dr. Fitzgerald, if you're in the room, if you'll come on up, please.
Follow the money. Hey there, how you doing? You're welcome. Hey, how you doing?
Doorkeeper, as soon as you can usher those folks out and get everybody in who's coming in. I appreciate you closing the doors, and let's see if we can restore order and get rolling. Get rolling. Thank you. Ladies and gentlemen, if you'll take your seats, we'll get started. Thank you. Appreciate it. This doorkeeper, as soon as you get that door closed, I appreciate it. It's kind of like your mama used to tell you, either come in the house or out of the house, one of the two. Dr. Fitzgerald, welcome. We're glad to see you, and the floor is yours.
Thank you so much. Mr. Chairman, members of the committee. The first thing I want to say from Public Health is we are enormously appreciative of your support, the support of the governor in making Public Health its own department. We think that was a good move, and we want to thank you for that to begin with. We are, as Public Health, are involved directly in two main goals of the governor's strategic priorities: healthy and safe. Clearly, we have major roles in both of these areas. When I begin the talk today, I want to mention some background information of which we are always aware, and that is the health of the population of Georgia is intricately tied to the health of our economy. Because if you have unhealthy people, if you have more obesity, diabetes, heart disease, you have higher health care costs, lost productivity, and you certainly do not have the incentive you want for companies to move here to Georgia. So we view public health's role as enormously important. Our main role in government in Georgia is, one, to protect the lives of the people of Georgia, and two, to decrease health care costs in the state of Georgia by the programs that we have for prevention, and also by using the information that we have and we analyze, because we are the holder of the state's information about health care. An example of protecting the lives of Georgians this past year was in the fungal meningitis case. You may not know, but when that occurred, it was Public Health's role to find those places in Georgia where the contaminated lots of medication had gone, to notify and find every single patient, and also we have established this year a network for communicating with the state's doctors. That had not been done before. We communicated with the doctors. We let them know about where the location of the contaminated materials were, so that they could be on the lookout when patients came to their offices complaining of vague symptoms, because the fungal meningitis presentation was really pretty vague symptoms. So it was important that doctors know exactly where the lots had gone, and we are thankful to say that we had no loss of life here in Georgia, and a lot of that has to do with the activity of public health. We're also doing something new this year, which is a statewide school-based flu program. Our data indicates that if you have flu shots in the schools, the children are more likely to get vaccinated, the teachers are more likely to get vaccinated. If more children get vaccinated, you have less loss of time from the schoolroom, and also you have less incident of flu in the population, because children are not exposing their parents to the flu. We continue to be aware of our responsibilities for emergency preparedness, and I'm very pleased to report that this year, when we had our CDC evaluation of our mass dispensing capabilities, and that's if there's bioterrorism, Public Health is the agency that is responsible for getting the antibiotics or the antidotes out to all the population. This year we scored 96%, and that's a significant improvement from 2007 when we were only 24. The other thing that we are aware of is our ability to decrease health care costs. One of the most important things that we think we have done this year is be very involved in the public-private collaborative to decrease elective deliveries before 39 weeks. If a child is born before 39 weeks, even electively, that means a repeat C-section, for example. If a child is born before 39 weeks, there's a greater chance that he will go to the intensive care unit, a greater chance that he will be on a respirator, and if you look at his test scores in 3rd grade, if you're born too early, you score less on your test scores in 3rd grade. Because of this, there are very compelling reasons, and we have joined with the March of Dimes, the Georgia Hospital Association, the Georgia OBGYN Society, the Georgia Pediatric Society, and we have jointly gone and had a movement to decrease elective deliveries before 39 weeks. The importance for Georgia is that in 2009, 65% of our deliveries were elective before 39 weeks. And as of September, it was down to 4.1. That's an enormous improvement, and we are very proud and very pleased with the collaboration and pleased with the efforts of our partners across the state. If you look at the amount of money that was spent on premature delivery, it was $191 million in 2010. So potentially, if we decrease prematurity, we have that savings for the state of Georgia and for its Medicaid budget. If you look also at the second item on the task force, which is a more interventional area that we're doing in public health, where we're partnering with the obstetricians in Albany to do pre-delivery care in the health department. And with that information and with that extensive care, we've significantly decreased prematurity rates for that population. The population for blacks in that county is 17.6%, whites 13%, and in the program, which is all comers, it's down to 5.6%, which is enormously important. If you look at Georgia's health indicators, I want to point out a few. We are the 2nd in the nation as far as problems with childhood obesity. We are the 5th in the nation for infant mortality, 5th in the nation for tuberculosis, 6th in the nation for AIDS and AIDS cases, 17th in the nation for our immunization rate, and 24th in the nation for our tobacco rate. Here's what public health has done this year. One, we are the agency that is the coordinating agency for the Governor's SHAPE initiative. I'm going to talk a little bit more about that at the end of my talk, but just be aware that it has been launched. It is the Governor's main health initiative, and we are so pleased that we are able to participate in this public-private partnership. Infant mortality in Georgia is down this year. It's down from 8.4 in 2006, which is the last number we had, to 6.3 in 2010. Again, public health is a part of a public-private collaboration to decrease infant mortality throughout the state. Last year, you gave us additional $350,000 for tuberculosis. We used that in Fulton County, DeKalb County, and Gwinnett County, and I can tell you that the new cases that we are seeing in each of those counties has been decreased, and we are very pleased about that. The progress in AIDS, I'm enormously pleased about. September of 2011, we had a waiting list of 1,700 people in Georgia. What that means is people with AIDS who are on a waiting list to get help with their medication. This is important because treatment is the only real prevention as far as AIDS is concerned. If you have someone who is adequately treated, there's a 96% chance that they will not pass it on to somebody else, and that includes mother-to-child transmission. So the most important thing Georgia can do is make sure that all the patients, and remember our incidence of AIDS, all the patients here in Georgia are adequately treated. And again, as of August of 2012, the waiting list was down to 0, and it continues to be 0. Immunization rates are up, as you can see, and also we have been working with each school district to have school districts have a policy where there is no tobacco on campus. We didn't have any schools with that policy in 2004, and there are 90 school districts by this year, which is about half of the school districts in the state, and that affects over 1 million children. Our total budget is approximately 27% state funds, and the rest is federal funds. I'm going to talk today, of course, about the recommendations we have for the changes in the state budget. I want to say ahead of time, because I know all of you are concerned about impacts it will have on your local constituency. We talked extensively with the district health directors, and when there was a recommendation to the governor for a cut at the district, that recommendation came from the district health directors. It was not a top-down process, it was a collaborative process. Also, I can tell you that the general grant in aid, which you all know about, is the monies that go from the state to your local health departments to be used to run the health departments. There were no recommendations for cut in that money, and none were offered in the governor's budget. I'm going to walk you through now our recommendations. First, common. There's a reduction in funds for property liability, which I'm sure you've heard about earlier today. Also, there was increased monies put in our budget for the GETS bill, for the telecommunication, of about $2.6 million. I can simply say to you that we were never fully funded, so we really need this $2.6 million so that we can adequately meet our GETS bill. And we are appreciative of the governor for putting it in our budget. Now to talk about the reductions. For adolescent and adult health, there were 3 vacant positions at the state in adolescent health that were eliminated. We had a reduction in, and again, this came from the Columbus area, a reduction in programmatic grant and aid of a small amount of money, and that was for the family planning clinic. We do not believe that services will be affected in the area at all. There's one increase, and that is the funds for the SHAPE contract. The SHAPE data, which was collected this year, is stored in the Cooper Institute, and this is money to pay for the storage of that SHAPE data. The next has to do with reduction of funds for hypertension. I can tell you that the decision to make this cut is not because we do not believe that hypertension is enormously important in the state, because we do, but the program had been cut and cut and cut, so frankly we had reached the point that we did not think that our monies could be effectively utilized. We are cutting part of the funds this year and the remainder of that program next year. The money that we do have, we'll keep in that program, will be used to provide medication for those people with hypertensive needs that are unable to pay for their medication. Administration. This is our largest cut. It will be difficult for the department, but again, we think it is enormously important that the cuts not be borne by the individual health departments in your districts. We are looking for ways, we are looking at every single way that we do administrative process in public health. That means that we are looking at how many people we need and how we can efficiently cut money in this area. We have begun this already. We've made significant changes in several areas, notably HR, and we will progress with each department at the administrative point in public health, and we expect to have this completed by June of next year. The emergency preparedness, this was one-time monies of $350,000 for a trial for the traumatic brain injury. And we are asking that this be cut because, quite frankly, we don't have the money to put into that particular program. On infant and child services, we did find one place where we could replace, and that's about the $475,000 federal funds for state funds. I also must tell you that we think this is probably the last chance that we will ever be able to do that. All the cuts to federal funds, the transition of state funds for federal funds, everything that is possible that we can find has been done. If you look at the next 2 cuts, one is for grant and aid to children's medical services. This is about a 5% cut in the monies that go out to the individual districts for children with chronic diseases. And again, this was a cut that was recommended or suggested, not recommended. Obviously, we're not a
place where there are good cuts. This was a suggestion that was made by the local health districts, and it'll be about a 5% cut in those monies. The next is a cut in the monies that we have used for hemophilia. The hemophilia patients are clearly patients with pre-existing conditions, and we can use those monies other ways, and this is a cut to planning on with the hemophilias, moving them to a pre-existing condition program. The next is a reduction in funds from Rome in the foster care program, and again, this was a recommendation from Rome. And the last is a reduction in program grant and aid for health check outreach. These are activities that are currently covered by the CMOs, and we felt this was duplicative. If you look at fiscal year 14, there are only four that I'm going to talk about, because all of the cuts continue, all of the increases continue. The differences are, in common, the employee retirement system employer share and teamwork billing. 2, it's down under adolescent and adult health promotion. The regional cancer coalitions are being transferred from the Department of Economic Development to the Department of Public Health, and we are very delighted with that move. We are pleased to have them. And the last one is under infant essential health treatment services, and that's a funding for Grady for the sickle cell disease of $150,000. And again, we are appreciative of that increased amount. The next page is a summary of where we spend our monies, and thankfully I'm not going to go over that at all. I do want to talk about, however, the next slide, and you can, if there are any questions, I'll be glad to answer them. This is simply how we spend our budgeted money. There is something that I want to talk about, and that is something that Public Health has done this year, is we now have telehealth capability in every single one of our public health departments. We have used this year to put the hardware in, the lines in, that can handle telehealth. We see this important in a lot of ways. One, we can clearly access for those parts of the state that are less populated, especially the southern part of the state. We can access medical services in the rest of the state more easily. These centers will be used for referral. That means anybody can go to your local health department and have a consult with a doctor anywhere in the state. We have combined this, and the reason it's on the same slide is with the Georgia Responds program. You created the volunteer health care program, and we think that this telehealth access will move from a position where doctors simply see someone voluntarily in a clinic to where it is a clinic without walls. Any doctor in Georgia that wants to volunteer to see a patient can see a patient anywhere in Georgia, and we are looking for ways to connect by the telehealth network with that doctor's office through our telehealth network, so any volunteer doc can see anybody across the entire state. The going live in February is the ability for a doctor to go online and register immediately. That means if you have someone that comes to your office and you want to give them free care, you can register immediately. The line will check their credentials. You'll get a ping back that said you are qualified to participate in the volunteer physician program, and then you can go ahead and see that patient. We expect there to be huge increases in the number of volunteer doctor visits. The reality is, and you guys know I was a doc for 30 years. Docs are pretty busy. The reality is we are more than willing to do our share. We're more than willing to help out. But if you can make it so it's reasonably easy for us, if you can make it so we can do it in our offices, there's a lot greater chance that we'll be able to do so. And one, we thank you for creating the volunteer health program. I see the author in front of me. And we want to make sure that it's expanded throughout Georgia. The last thing I'm going to talk about is Georgia Shape. Georgia Shape is important for a lot of reasons. It's important economically. As you can see, it's about $2.4 billion in direct medical costs for the latest year we have. That is predicted to increase We know that the obesity-related hospital admissions for children in this state has increased 338% in the last 10 years. We know that if we are able to impact the lives of our children, we can significantly affect the amount of money that we spend on health care and certainly affect the lives of our children. Last year, the fitnessgram was done in all 182 school districts. Here are the numbers. 20% of the children did not pass any of the 5 basic health tests. And we're not talking about trying out for the football team. We're talking about basic health tests. 43% of our children were not a healthy weight, and only 16% passed all basic measures. Public Health is committed to decreasing childhood obesity, and I can tell you we have an active and viable partnership throughout the state, and I expect to make great progress. So when I come to you next year, hopefully I can tell you some progress on that front. I'll stop now, sir, and if you have any questions.
Commissioner, appreciate it. I don't know whether it means anything or not, but it appears the last 2 speakers have been in here talking about obesity, and I've been looking around. We're feeling a little uncomfortable up here. I don't know about y'all.
Well, sir, there's obese and there's fluffy.
We do have some questions, and I'm going to put
fluffy then.
I'm going to put a 10-minute limit on it because we are holding up 2 other speakers, and then we've got the block grant here this afternoon, so we're going to move ahead. But we've got 4 speakers right now, and we'll try if we can get those in 10 minutes. First one is Senator Tate. Let me get you turned on here. Gotcha. I'm sorry.
Commissioner, I appreciate those comments, and especially the obesity situation, because that's one of the things that Kara Steele Pitts is moving to. But I have 2 questions for you. I'm going to make them real quick, and hopefully you can answer them quickly. Can you give us an update on what's happening with Babies Can't Wait is the first question. And then the second question is how many people will lose services as a result of the $600,000 cut to hypertension services in the Adult Essential Health Treatment Program, which is, you've mentioned that, but if you could give us that information, I appreciate it.
Certainly. While Kate looks up the number of people that will be affected by the program, let me give you an update on Babies Can't Wait. Babies Can't Wait is the program that the state does in the first years of life to help children with developmental delays. And about, I don't know exactly when it was, 3 or 4 years ago, a decision was made to change the funding mechanism for Babies Can't Wait from a payment of last resort to a pay and chase model. And that went into place in June before we became a department in July. It just started then. So the first year, we just observed it. We had some extra money, ERA funding, that we could fund it. So the first year, we allowed the program to get in place. The first quarter of the next year, and at this time we no longer have ERA funding, I looked at that program, and basically we had about a $10 million budget. We had paid out $4 million and recouped $150,000. Obviously, the pay and chase was not an ideal model. So what we did was we worked with the provider community, with the physical therapist, and we met with them first, and we said, this is not a sustainable model. It's had a whole year to get up and running, and it's just not functioning very well. So we worked with the provider community. We said and they were very helpful in suggesting things that we could do. We we changed it with a month notification for the providers to basically the payer of last resort, which is what the money should be used as. We think that with that change, and again, it was after 1 quarter, that the program will be viable, and we think that we will be able to sustain Babies Can't Wait. And we are using this opportunity to look at what they're doing in other states, because in other states, they get a lot more funding from different sources, and they do a lot more for babies. And so we are using this as an opportunity to transform the program so it serves more children. The first 6 months, this first part will be, financial. I mean, we've got to get our financial feet under ourselves. But by the beginning of next year, we are looking at what other states are doing. We intend to roll out some improvements to the program. And the number of
because that's a very vital program for our community.
Absolutely. We absolutely agree with you. And again, we can't have a program that we have no money in. And but we really feel positive about that. I think that that's going to be it's going to be fine. The number of clients we serve are 3,381. It's in 5 districts: Whitfield, Lawrence, Richmond, Daugherty, and Clark.
One other quick thing. You did give us a copy of your slides.
Yes.
Can we get a copy of that? At least my office, that would be helpful.
Yes, we will absolutely get a copy.
Thank you so much.
Yes.
Senator Ford.
Good morning. I want to ask a couple of questions about the hypertension program, further questions, because I'm looking at the amended budget, and you're proposing a $511,000 cut, and then in the FY14 another $600,000.
Yes, sir.
You went through a litany at the beginning of your presentation, which was very impressive, about where Georgia is in terms of a lot of indicators. And if you had used hypertension, I think Georgia would have been close to the worst. I'm very concerned in the high blood pressure belt that we are in. We're kind of the buckle of the high blood pressure belt, that we're cutting that much on the hypertension program. How many people are going to lose? Are we going to lose? What are we talking about there?
Yes, sir. I agree with you. Hypertension is a huge priority for the state. Let me tell you about the decision process and why we came to that particular thing. We know in public health, and we know in these financial times, there are limited dollars. One of the decision points we used was, let's make sure that those things that only public health does, that we keep those positions as strong as possible. The number of patients that will be affected was 3,381. That's the number of clients that we now have in our programs. It indeed is an enormous problem for the state. There are a lot of places where there are treatment available for hypertension, was our only thinking. Certainly, we would love to develop, again, public-private partnerships where we can expand the limited resources that public health does. We're talking with one particular health group now, using a model that they used in North Carolina. And they used it for asthma. And this was not public health providing the main service. It was public health being a supportive to the private practitioners providing the service. And they noted in North Carolina there was a significant decrease in the amount of asthma readmissions. So there's lots of stuff public health can do. But again, we have limited resources.
Mr. Chair, just to follow up very quickly, I hope we would continue to think about that.
Absolutely.
Because the added costs in terms of strokes and long-term care, heart disease based on hypertension, as you know, doctor, is significant. So I hope we will continue to think about that.
Absolutely.
Because we're in an epidemic of hypertension. Thank you.
Senator C.
Thank you, Mr. Chairman. Thank you, Commissioner. You have a pie chart that had a significant amount of monies coming from the federal government.
Yes, ma'am.
So my question is, how badly would the department be hit if sequestration moved forward on the federal level?
Sequestration will be devastating. I mean, there's no question about that. We are not exactly sure exactly how much. We have a hypothetical model that's been put out by our National Association of Public Health Departments, and they see a decrease in maybe 5.3% of those monies. But that's hypothetical. We have not seen, obviously if sequestration occurs, we don't know exactly how much will be taken out of public health's budget. But the hypothetical thing we have is 5.3, which obviously would not be good for Georgia Public Health. Yes, ma'am, it is.
Representative Henson.
Thank you, Mr. Chairman. Commissioner, thank you for your presentation. My concern is with dentistry, and I'm going to run through the questions really quickly. Adults. Are adults being treated at all by dentists in public health if they have a toothache? Because I know...
Yes, it's not, the dentistry program is not universal. I will be glad to get back with you and tell you exactly where there are dental clinics available. There are some that are very active, like in the Savannah district, I know that there are very active dental programs for both adults and children. And I know that there's some particular things in like Waycross, because that was where our teledentistry started, and they use a teledentistry to take the carts to the schools and screen children and then refer them to dentists in the area. So that's a pretty innovative thing that we're going to increase.
My big concern, of course, is adults, right, because they're barely covered at all under Medicaid. And there's so many folks out there, there are virtually no free clinics, and going to a dentist does cost a lot of money for a lot of folks on very limited incomes. So I have a grave concern about that because of people being in pain, having toothaches, things that really can't be treated through telemedicine or teledentistry, or whichever way you want to say it, that yes, they actually need hands-on by a dentist. So I'd like to talk to you further about that.
Absolutely, we'll be glad to. One of the things I know, Kate just reminded me that there's a very active program in Rome. I know there's several pockets across the state that do have active adult programs. I can also tell you that my hope is we are appealing to the dentist to be part of the volunteer health care program, and we're appealing to them when we get online and we're sure that people can be checked online. We're not going to send out the notification. I guess they may hear this today, though, mightn't they? but we are going to appeal to dentists to be part of the volunteer program, and we think that's some answer. But you're right, there is a great need in the state.
I guess I just have to follow up on that, but the biggest problem you have with a lot of the dentists that might possibly be in the program is they take Medicaid and Peach Care, and that's reimbursing them at about 40% of their cost. So they already feel, in a way, that they're doing a lot of free dentistry because they're certainly not making money on that. And, I mean, it's a grave problem in having enough dentists to treat the patients out there.
Commissioner, I think we did get the questions in. We appreciate you coming today and the great job that you're doing with public health.
Thank you, sir.
Thank you so much.
Thank you again.
Thank you, ladies and gentlemen. We're going to quickly move into revenue and try to wind this up with the Office of Planning and Budget. So if y'all will help us move quickly. Thank you.
Which one? This one here? You want me to stick these just in case? You can sit in the back. Okay. Hey, I'm gonna.
Commissioner, we're ready when you're ready, if we can get them to settle down out there. Just doorkeeper as soon as you can. Try to get that door closed.
Everybody left.
Trying to do this presentation. Commissioner, we appreciate you being here today, and sorry we held you up a little bit. We're trying to wind it up here, but we look forward to your presentation and hope you have a few questions.
All right, we will move quickly through the slides since I know it's at the end of the 3 days and end of the day. In terms of initiatives at the department, I think you can divide them into pretty simple categories. First, we try to answer the phone and try to answer the phone quickly. You can see that we've driven down our answer time significantly. They're in the single digits. Our goal is to keep them there indefinitely. Along with that, we try to keep our abandonment rates down. That's when somebody calls, hangs up because they can't get somebody to answer their question. Again, that should be in the single digits, and it's been there for most of this year. The spike in early 2012 really had to do with a new fraud program we were running. I think we've ironed the kinks out of that, and my expectation is that those numbers will stay low as well. So we try to answer the phone, too. Our goal is to handle work items. That's questions, appeals, protests, or whatnot, the day or the week it shows up. We are not there yet, but we have made significant progress in knocking down what were significant backlogs at the department. You can see the numbers. When there's a big round number with a plus sign, that basically means we didn't know exactly how many of them we had. We can now measure our inventory, and we have made significant progress just getting rid of backlogs, and I think taxpayers have seen the benefit from that. This slide I'm going to quiz you all on later. I don't expect you to read it. All this shows you is that the tax dollars that you all invested in computer systems at the department, we can now use, and we can run reports on the inventory in our system. So work items in our system much more efficiently than we used to. This is just a report that shows all our backlogs by date. We can measure where they're at right now by work item. And we have a very good idea of what is in our house, what our inventory is, and what we need to be working on. So that's just a representative slide from the system. Greg will correct me if I'm wrong, but I think the department spent over $40 million of taxpayer money implementing the new system, ITS, and it's just one of the real benefits from that system that we are running. The other thing that we are working on, the third initiative, would be fighting fraud here in Georgia. This shows the number of returns that the department blocked by fiscal year and the total dollar amount of refunds that we blocked that we believe were fraudulent. In calendar year 2012, so a little different shot, this is fiscal year shot, we blocked 160,000 returns totaling $98 or $99 million. It is a significant problem here in Georgia. I think we do a better job of blocking than we do prosecuting, though yesterday there was a couple news stories about a couple individuals were arrested for tax fraud. They had filed 130 fraudulent returns for $134,000. That was dollars that had already gone out the door that we were able to track down. We will not get $134,000 back. These are just the dollars we're blocking, and we are 100% certain that we do not block 100% of the fraudulent returns that are filed. It's a big problem. And we're doing the best we can, and based on our interaction with other states and the IRS, I can tell you that we're doing more, at least as much, and certainly more than most every other state out there, but it's still a big problem. The fourth initiative would be being more efficient in our compliance efforts. Compliance are just simply when we find taxpayers who are not paying their what they owe. Either they're not paying anything or they're paying less than the tax laws require. We find these folks through audits, through revenue agents, through voluntary disclosure, any number of means. You can see that both the dollars collected and the number of accounts. One of the significant reasons you see much fewer accounts but greater dollars is in 2 of those years we ran a program around taxes on automobiles that generated huge numbers of accounts, but not very many dollars. That's been phased out as the state's gotten out of the ad valorem business, and so the accounts have come down. The other thing that you should see, and I think you see in the last couple of years, is our system allows us to be much more efficient to target taxpayers who are not paying their legally required amounts. And so the sort of account to dollar ratio ought to continue to improve. The other big thing that we are working at the department is implementing tax reform legislation that was passed last year. I won't comment on all these, but to the extent you have questions, I'm happy to answer them. Applying e-fairness, working with the new tax court that's been implemented, working on regulations and administration for the new exemptions around sales tax on inputs in agriculture and manufacturing. We have worked closely with the Department of Agriculture in setting up the system. I think we have done a good job, but there will certainly be some kinks in the hose that will need to be ironed out as both of these are implemented. And then finally, the title transfer tax around automobiles or the title ad valorem tax. That go live date is March 1. We are on schedule to hit that date on March 1 as the law currently sits. I know there's some discussion about making some changes to that law, and we've certainly worked with everyone here to talk about timing and how that can work going forward. But right now it looks like we are good to go on March 1 and have been working closely with all the interested parties in implementing that. In terms of budget issues, like everyone else, we will take some budget reductions, and I'm not going to go through the line items, but if you think about the Department of Revenue, what we are is we're a huge data processor, right? We bring in $20 billion a year. That all comes with the tax return. We have 4 million individual taxpayers, 250,000 business taxpayers, and we have to we immediately take the money and flip it over to the state treasury, but we have to keep and manage all of that information. So we're a big data processor. The two costs of running the Department of Revenue are information technology and people. That's it. We don't run programs. That's 75% of our cost. The rest of our costs are pretty fixed: rent, postage, license plates that we manufacture. So when we reduce costs at the department, we're either taking it out of IT or we're taking it out of personnel. And given our relationship and the GETS relationship, our ability to take cost out of that is limited, and so most of the reductions will be at the personnel level, primarily at the compliance level. You can see we've been managing our headcount down over the last year because of budget pressures. We're able to operate somewhat more efficiently, but obviously have to take the costs out of somewhere, and I think you'll continue to see that number come down as we implement these budget reductions as well. Then finally, on the bond request, the last ugly computer system that we have at the department is the one that we're reprogramming for the motor vehicle system, or the motor vehicle division. It is an old mainframe programmed in COBOL, and I'm not a computer guy, but I'm told that I tell a little joke when I speak to roadies. We're pulling people out of retirement homes to help reprogram that system right now. The request is to rebuild that system. It'll be the last system that we have to rebuild at the department. I can't tell you if it's the next best place to spend tax dollars, but certainly from the department's perspective, it's the next best last place to spend significant IT dollars to build a new system that is much better to run, much easier to manage, much easier to make changes to as we go forward. If you ever want to see government the way most taxpayers picture it, you need to come down to our motor vehicle division and see the piles of paper that we have to move manually at motor vehicle to move titles, to transfer ownership. It's not pretty, and our system makes it that way. So that's the reason for the bond request, and I believe it's in the governor's recommendation. I'm happy to answer any questions. I was instructed by Representative Chairman Reinders to move quickly. I've done that, but I'm happy to answer any questions that you might have.
Well, as long as you follow Representative Reinders' request, then you'll be all right in here. Okay, we got a couple of questions. I believe Senator C is first. Just one second, I'm sorry. I'll get you on. There you go.
Thank you, Mr. Chairman. Commissioner, one question I had, well, two actually. Sales tax and potential tax revenues that's going uncollected, what is the department doing about that? And recently we keep hearing I started hearing in both the print paper and the media paper about Amazon. Can you speak to those uncollected taxes and what are we doing as a department?
Sure. The department obviously takes seriously its obligation to collect all the taxes due under the laws of the state. We have any number of programs that we run to try to identify folks who are underpaying or undercollecting and underpaying sales tax. We have auditors in the field We have revenue agents in the field. We use the technology that we have to run reports on filers and non-filers, and we run any number of campaigns that way, and collect a lot of dollars. I mean, a lot of those compliance dollars that you saw, if you go back, the $200+ million a year is sales tax that we collect from folks who are not paying. In terms of the question on e-fairness, Georgia law prohibits me from commenting on our activity vis-a-vis any particular taxpayer. The Attorney General has advised me that I can tell you that we are vigorously enforcing, or will vigorously enforce, the e-fairness law, but I cannot comment on our activity with respect to any particular taxpayer. We are certainly aware of the press. We are aware of what the law says, and we will enforce it just like every other law. You know, there's some discussion about whether the law is constitutional or not. That is not our job to decide. We will enforce it and let the courts decide whether there's a constitutional issue or not.
Representative Yates.
Commissioner, I've heard in the news reports that due to Congress delays that tax dates will be changed by the federal. Have you heard anything on that, and does that affect the state? It
does affect the state, but it's only on the front end. So the federal government will start receiving tax returns on January the 30th. The normal flow is they go to the feds, then they come down to us. So we'll start receiving tax returns on February 1st or 2nd. But the end date will not be changed. So April 15th will still be the final date on which folks must file their tax return.
Thank you. Representative Burns.
Thank you, Mr. Chairman. Thank you, Commissioner. Appreciate the job you're doing and your staff. My question is a more practical question as we look at all of the new changes in statute and some changes you're dealing with. How are we communicating with the local folks that are where the rubber meets the road as they deal with the public to make sure they have full information, they're educated and they're trained? Are we doing that by meetings with them, or are we doing it by using technology to make it simple and easy for them to garner that information and do a good job dealing with our public?
The short answer to that question is all of the above. In particular, on the changes in the title ad valorem tax, we have worked very closely with all of the county tax commissioners and other interested bodies out there, the dealers, both the GADA and the GIADA. From the beginning of the project, we've incorporated their input into it. We have run training sessions across the state, both for dealers and for county tax commissioners and the desks that they run, because I think, as you know, the rubber will meet the road there. That's where all the transactions will take place. It won't take place at the Department of Revenue or here. It's when an individual walks into the county tax office and says, hey, I bought this car, I have my title, I like my new title. That's where the transaction has to take place. So we're actually right in the middle of running system testing down at the department, where county folks have come in. They're trying to break the system so we can fix all those errors. I have a list of dozens of meetings that we've had with those folks, and we've worked very closely with them to try and make sure that there's as seamless implementation as possible. I can't guarantee you that there will not be some issues just because it's a big change, but I think we've done a very good job in educating those folks. We've also had webinars. We put together online manuals for folks and try to distribute them electronically as well.
Thank you, Commissioner. And I would just say...
Do you have a follow-up?
If you don't mind.
Sure. Okay.
Thank you, Mr. Chairman. It's very expensive for our local folks to travel from all over the state to different seminars, so as much as we can use technology, that sure does help us on the local level to continue to live within these budgetary times. Thank you, sir.
Absolutely. And just so you know, all those seminars haven't been here. Actually, they've been all over the state. We've sent our people on the road.
Sure. Thank you.
Representative Hughley.
Thank you, Mr. Chairman. Mr. Commissioner, can't go home without asking you where we are on getting point of sales data, because our city asked us for that every year. Where we are in that regard, and as you're making these new improvements, is that on your agenda at all?
I think this will answer the question, but if it doesn't, please ask it again or ask it differently. The way the sales tax system is set up in Georgia today by code is that merchants collect sales tax. Pick your hometown retailer. They collect the sales tax, and they remit it to the state. And they're required to remit it by county. That's all the state asked for. That's all we've ever collected is sales tax information by county. The state then takes that sales tax, divides it between the state portion, the 4%, and then the county portion. We then send the money either to the county directly, and then each county has whatever relationship it has with cities to divide up that money, or at their instructions, we send it both to counties and cities. But the relationship in state law has always been, it's at the county level, and the state deals with counties. It would require legislative changes for us to collect that sales tax information by city, and I make no comment on whether that's a good idea or a bad idea. I think you'd hear from both sides of that equation if you chose to make that policy decision. But the state has never collected information by city, and as law sits today, that's not something we feel like we can do on our own.
Let me just clarify. Columbus, we're city county, we're consolidated, so that was not what I was getting to. What I was getting to is, when will we be able to have a system whereby our local counties will know where the sales tax is coming from, so that as they plan their economic development activities, they will know what type of businesses are prospering in their part of the world?
So they can get some of that information, but again, the law in Georgia prohibits the disclosure of individual tax information. So if somebody wanted to find out how much tax was being collected at, you pick a merchant in Columbus, Georgia, state law today prohibits that. It would require a significant policy change at this level to make that information available to local governments.
Senator Davenport. Oh, sorry.
I'm done.
Oh, okay. Senator Davenport.
Thank you very much, Mr. Chairman. Commissioner, just a question. What is the total amount that Georgia has spent since 2004 on corporate tax breaks? And really, how many jobs have been created as a result of that? Kind of talked about those tax breaks and incentives yesterday to the Commissioner of Economic Development.
I would impress myself if I could give you that off the top of my head. I have no idea what that number is, but we can certainly get it for you.
Thank you.
The former number, we can get some of that. Our systems may make it difficult in those early years. Certainly today we can tell you how many credits people are claiming. The jobs number is not one that the Department of Revenue would be keeping except for certain types of tax credits.
Okay, very good. Thank you very much.
Okay, Commissioner, I think you've exhausted them. We appreciate very much your good work y'all doing, and we'll continue to work with you.
Thank you.
Thank you. Teresa McCartney with OPB is going to come up and wrap it up for us. Mr. Doorkeeper, if you can help us get that door closed as quick as you can. Thank you. Okay. Very good. Okay, ladies and gentlemen, if you'll give us your attention, we have Teresa McCartney, who's the Director of OPB, and Commissioner, or Director, thank you so much for being here, and you can kind of put an exclamation point on this, on these proceedings for us. Thank you.
I'm going to see if I can make a record today and see how fast I can talk. See if I can talk faster than Chris Kaminsky, which is probably a very difficult task to do.
All right, we got a stopwatch. We're going to check you. You can be Kaminsky, you're pretty fast.
Yeah, I will forewarn you that people do say I tend to talk very fast. So at any point, if you have questions, even after today, my door is always open and we'll be happy to help in any way possible. But first of all, I really just wanted to thank everyone for the opportunity to come and finish out the hearings today. And I do understand I'm between you and lunch. Chairman England and Chairman Hill, I will be very, very quick today. First of all, thank you for the cooperation between the House Budget Office, the Senate Budget Office, and OPB during the fall. The three budget offices met together and agreed upon the performance measures around 57 of the programs that we did zero-based budgeting on. We'll continue to work with your budget offices to identify measures for ZBB programs that the agencies should track in the future to better reflect program outcomes. Governor Deal is intent on making state government more strategically focused and accountable for performance, and he'll continue to publish performance measures in his budget reports. We do provide a limited number of performance measures in the budget book, but provide the full list of performance measures on OPB's website. Really won't go into revenues. You heard from Ken Hegany on Tuesday. Again, if you have any questions around the revenue estimate and what we set for the amended 13 and 14, we'll be happy to provide you any information. Really wanted to focus today on zero-based budgeting. As you know, the governor signed the Waste Reduction Act in 2011. The legislation requires OPB to implement zero-based budgeting as part of the budget development process. We worked on doing ZBBs on 57 programs. I will tell you it is time-consuming given the limited staff, but we do feel that it is a learning process, and I think as the years continue that we'll be able to do more around zero-based budgeting. Just wanted to provide a few highlights. We did do the analysis on 57 programs, including 23 programs in the Department of Education. It resulted in approximately $22.4 million in program savings. It represented about 46% of the total state funds budget, about $7.7 billion in those 57 programs, which really equated to program savings of about 0.29%. Given the budget reductions over the years, that's really eliminated a lot of the low-hanging fruit. So I don't think you're going to see massive savings coming out of zero-based budgeting, but I do think it's a great opportunity to look at how we can improve efficiencies within departments and see if there needs to be additional alignment. Some of the things to point out, zero-based budgeting, we did recommend about eliminating 31 positions. Some of the big ticket items that are showing up in the press is especially around the alignment of the Department of Education's central office program. Again, that was just to better align the administrative side with program budgeting to have a better understanding of how the funds are being spent. You see some general other changes of recommendations of reductions and limitations of low utilization programs. Some examples would be the Life Sciences Center of Innovation, the Energy Center of Innovation, the Georgia Medical Center Authority, and the Wilderness Program. But again, overall, relatively small savings from ZBB. As far as OPB's budget, all of the attached agencies, OPB, we reduced our budgets by 3%, both in the amended and 2014. Like all agencies across the state, we're having to do more with less. But definitely will not complain and will always continue to try to move forward. We did have an agency head meeting yesterday, and I try to joke with the agency heads that we do understand the budget that was submitted is not perfect. We understand that there's a few issues around some of the statewide spreads and little things like that that we'll work with both the House and Senate and figure out how to fix some of those. But again, we're here to answer any questions that you may have around the governor's budget and look forward to working with everyone. How did I do? Was that fast enough?
Pretty good. Mr. Chairman, you want to make a comment? You want to ask a question?
I just want to reiterate kind of what you touched on. It's been nice working with y'all through the summer and fall and everything, and of course look forward to working with you as we go through the amended budget and into the 14 budget. And you know, it's one of those years. It kind of makes it easy on Chairman Hill and I, because when there's no money, we get to say no pretty easy. It makes it more difficult when there's a little bit of money to spread around. We have to pick and choose who we say no to. But just want to commend you on a good job and looking forward to working with you.
Thank you.
Teresa, I think I told Chairman yesterday, I said this is about as clean a budget as I've ever seen, and there's not a lot of cuts that we got to go back and, address. I mean, that get our members all riled up, and we got to, to me, y'all took a pretty good approach at it, and it seems to me like the process should go really smooth this year. I think I know it's a really tough year, and revenues have not grown the way we would like for them to grow, but there are some green shoots of recovery out there. We hope that we can continue to foster and grow, and we do believe we've got the best relationship going with y'all that we've had in a while, and we're certainly looking forward to that. Thank you for your hard work. I know this has been a tough first. I'm not searching for the right word for you, but you were thrown in for sure in the very beginning. So
I think I've officially hit 3 months on the job. So.
Yeah, there you go. But thank you so much, and I know the members of the committee look forward to working with you. So thank you very much. Ladies and gentlemen, thank you for your attention this week and for your hard work, and the real hard work just begins. So thank you very much. Block grant hearings at 1:30 in this room. Thank you. We've already.
All right, let me call this legislative public hearing on block grants to order. We apologize for the delay with the interpreter and with us figuring out the speaker system. Let me introduce myself. I'm Tim Golden. I represent District 8 in the State Senate. Sitting on the podium with me is Representative Katie Dempsey to my left, and Sarah Dunn representing the House Budget Office, and Clay Buckaloo to my left representing the Senate Budget and Valuation Office. Demetrius Taylor is Budget Director for the Department of Human Services, and Lee Wright is the Director of Budget and Finance for the Department of Behavioral Health and Developmental Disabilities. Before we get started, is there anyone who requires sign language interpretive services? If so, please identify yourself where the interpreter can position himself. Thank you for attending this block grant hearing today. The purpose of the hearing is to receive public comments on the use of 5 human service block grants that Georgia receives from the federal government. The hearing also provides the members of the legislature the opportunity to listen to views of private citizens and other interested parties on how the block grants should be used for the state fiscal year 2014 budget, which begins on July 1st of 2013. These block grants are community mental health block grants, community service block grants, low-income home energy assistance block grants, social service block grants, and substance abuse prevention and treatment block grants. Public input is an important aspect of the deliberative process that the legislature undertakes in making decisions about our state budget. I appreciate you taking the time to participate in this process. And at this time, we're going to recognize Demetrius Taylor, who will provide a brief summary of the grants and explain how we will proceed. If you would, please welcome Mr. Taylor.
Thank you, Senator Tim Golden. As Senator Tim Golden has told you, the Department of Human Services will receive public comments on 3 federal block grants today. By federal law, Georgia is required to hold these public hearings today. These grants. These grants are the Community Services Block Grant, Low Income Home Energy Assistance Block Grant, and the Social Services Block Grant. At this time, I will give you a brief overview of these 3 grants. The Community Services Block Grant provides funds for services and activities that impact the causes of poverty and to assist low-income participants. These funds are distributed to local agencies throughout the state and fund a wide range of services, including employment, education, meals and nutrition services, and home services. The Low-Income Home Energy Assistance Block Grant provides cash assistance to qualified low-income households for home energy costs, weatherization costs such as insulation, caulking, and weather stripping to reduce energy consumption and for energy crisis intervention. Finally, the Social Services Block Grant funds various services such as daycare services for children, adults and persons with mental retardation, home delivered meals, homemaker services, transportation, and protective services for adults and children. This grant also assists families to achieve and or maintain self-support and self-sufficiency. At this time, I'll call Lee Wright, the Department of Behavioral Health and Developmental Disabilities Director of Budget and Finance, will provide a list and a brief summary of his agency grants.
Thank you, Marshall. The Department of Behavioral Health and Developmental Disabilities will receive public comments on two federal block grants today. These two grants are the Community Mental Health Services Block Grant and the Substance Abuse Prevention and Treatment Block Grant. Here's a brief overview of each of these grants. First, the Community Mental Health Services Block Grant implements the provisions of the Mental Health State Plan by providing services to individuals with a serious mental illness and to children with a serious emotional disturbance. The second grant, the Substance Abuse Prevention and Treatment Block Grant, provides funds for community-based alcohol and drug treatment, prevention, and early intervention programs. Thank you. Now I'll turn it back over to Marshall to continue.
More details about each of these grants, including types of programs that can be funded and their proposed funding levels, are included in the color-coded pamphlets that are available on the table. There's a separate pamphlet on each grant. Before receiving your comments, let me go over a few ground rules. We will take speakers in the order in which they sign up to speak. If you have not signed up yet, you may do so outside at the table. Please give us your name, name of the organization you represent. If there are more than one representative here from the same organization, please choose one to speak in reference to your organization. By doing this, we will ensure that each organization and citizen gets a fair chance to comment. You will be given 5 minutes in which to present your comments. There is a timekeeper who will let you know when you have 1 minute left. I will initially call 2 speakers to the podium at a time. As the first person is speaking, the next speaker should be making his or her way to the podium. Then as I call your name, please make your way to the podium. If you have written comments for the record or a copy of your speech, please place these on the table at the end of the meeting. Now let's begin. First up is Ann Williams from GCOA, and then next up is Nancy Petra.
Okay, I'm Ann Williams, Legislative Chair for the Georgia Council on Aging and an advocate for Georgia's seniors. The Council, in its advisory capacity to state government, wishes to address the allocation of social services block grant funding for seniors. SSBG monies are allocated to local communities through contracts with the Department of Human Services, the Division of Aging Services, to provide services that enable older Georgians to continue living at home in their communities, often delaying or completely preventing nursing home placement. SSBG monies also help to ensure that Georgia's most vulnerable adults are protected through Adult Protective Services and the Long-Term Care Ombudsman Program. Both of those work to improve the lives of residents of long-term care facilities. In recent years, SSBG has supported the Money Follows the Person program, paying for expenses like clothing and furniture for persons coming out of institutional settings back into the community. The Aging Network utilizes SSBG funding to provide home-delivered meals, homemaker services, adult daycare, respite care, and transportation. These programs support the individual at home, improve quality of life, and reduce the burden and high cost of nursing home placement on the family and the state. These services cost, on average, $1,800 annually, while nursing home placement costs over $30,000 to Medicaid annually. This network of services encourages those who voluntarily care for an elderly family and friends, providing them with resources rather than supplanting their valiant efforts. Georgia's population of adults over 55 years of age grew by 45% in the past 10 years, compared to overall population growth of only 18% and growth of 15% for children under 19 years of age. However, the share of SSBG funding allocated for aging services has remained unchanged. Georgia continues to allocate a small percentage of SSBG funding to aging services, while Georgia's older population is growing at a faster pace than most other states. It's our hope that you will review the data on these shifting demographics and take action as legislators to enhance funding for services for older adults and their caregivers, rather than leaving the allocation to the department, which has not responded to the changing population. We again ask that you consider increasing that allocation to better reflect the growth in the older population. The Council is often alone in giving testimony at this hearing, and we have asked for this consideration for a number of years. In the meantime, the population and the need continues to grow. And again, we're asking you, and we thank you for the opportunity to testify before you. Thank you.
If I can get this up, I'm a little taller. Good afternoon. My name is Nancy Petra. I am the coordinator of the Senior Citizens Advocacy Project. This is a collaboration of the Georgia Gerontology Society, the Georgia Council on Aging, and the Georgia Area Agencies on Aging. As you've already heard from Ann Williams from the Council, the population of older adults in Georgia has grown rapidly. And I know you heard a little bit of this morning in your budget hearing too from Commissioner Reese. But services for Georgians are, access to those services is vital and critical as our older population is growing. Money Follows the Person is a program at the federal level that Ann mentioned that provides transitional support for these older adults that are leaving institutions so that they can live independently in community settings or in their home settings. But sometimes during these transition processes, there are minor support needs that are essential for them to live that way. Furniture, clothing, maybe some sort of basic toiletries, things like that that maybe the federal program won't cover. Also, sometimes these people are, during the transition period, are already in that stage of being moved out when they find out for whatever reason, Money Follows a Person isn't going to cover that transition. In both of these types of circumstances, the Division of Aging Services has been successful in going ahead and using these SSBG funds to go ahead and get those people moved out. That's a win-win because that allows that person to live independently and at home, and it's a win for our state budget because it takes that money, it makes less of an impact on our state funding for Medicaid and other sources. Also, when we allocate these SSBG funds to deinstitutionalize older adults, when program like the Money Follows a Person funding cannot be used, it unfortunately reduces SSBG funding for other necessary and vital support, things like homemaker services and meals and respite care, as you heard from Ann that we actually need that money for as well. And the Division of Aging's budget for fiscal year 2014 is also facing a budget reduction for these types of direct respite services. So these SSBG funds are extremely necessary so that those living with dementia and Alzheimer's and their caregivers, we can make up some of that hole that we have right now with our budget constraints. While SSBG funding is allocated in the same way year after year, we are asking that you consider taking this opportunity to find more creative ways to use the SSBG funding without harming any of the groups you're trying to serve. With the Olmstead decision and current focus on deinstitutionalization, SSBG funding provides a flexible vehicle for supporting community services and softening the growth curve that we are facing with Medicaid. At a time when elder abuse is on the rise, additional SSBG funding could lower the Adult Protective Services caseloads without an allocation of new state funding. Georgia's APS, or Adult Protective Services caseloads, are behind national standards already. Complaint investigations are sometimes taking longer than 30 months and placing all these at-risk adults at high risk. With a heightened and welcome focus from law enforcement on bringing abuse, neglect, and especially financial exploitation cases to prosecution, we must have the infrastructure to place case investigations at an all-time top of our list, as well as guardianship for these at-risk adults. So these SSBG funds could be vital to helping us fill that hole that we have in some of our state budget right now for fiscal year 2014. Use of state funding in DBHDD waivered services rather than federal SSBG fundings is also another alternative that would allow Georgia to leverage greater Medicaid funding and free the federal funding to address needs served by the Division of Aging Services that they can't do right now. Currently, 40% of the Adult Protective Services cases have a mental health or developmental disability diagnosis as well. But the SSBG funding doesn't follow those the way that some of the Medicaid monies do when they get out into the community. We understand Georgia may be facing a reduction in SSBG funding. We don't know what's going to happen at the federal level. The money may not be there at all. But if the money is there, we do ask that when a time when our aging population is steadily increasing and our state budget is tight for aging services, and aging services taking a large cut, that Georgia cannot afford a cut in these SSBG funds if they're available. Last year, I believe Georgia was allocated around $53 million, and Division of Aging Services got about $9.5 million of that. We encourage you to maintain the level, if not increase that funding to the Division of Aging Services so that we can protect our older adults. This will enable the division to continue to provide vital and necessary services, as well as continue to deinstitutionalize our individuals and help with emerging needs as this population continues to grow. Thank you.
Our next speaker we have is Kathy Simpson from the Georgia chapter of Alzheimer's Association.
Thank you, committee members. We appreciate the opportunity to share our comments. The Alzheimer's Association represents approximately 120,000 Georgians currently diagnosed with the disease. Unfortunately, we believe those numbers are extremely low because the diagnosis of Alzheimer's is difficult and oftentimes takes years to accomplish and takes a long time for families to understand that dementia or Alzheimer's is occurring in their family member. As of 2009, only 16% of residents in Georgia's nursing homes did not have some form of dementia. 45% increase in dementia in Georgia recognized between 2000 and 2009. Right now, there are over 800,000 individuals with Alzheimer's living alone. 60% of individuals with Alzheimer's and related dementias live in homes with families, not in nursing homes. In Georgia, as well as nationally, 800,000 of those people live alone. Many of them do not have caregivers, do not have family members who can assist them or look out for them. It's an imperative that we take care of our frail elderly, particularly those with Alzheimer's and dementia. Without the support, the security network of adult protective service workers focused on the needs of the frail elderly, we are doing our seniors a disservice. Other groups in our population are important, but our seniors have laid the groundwork for us. They raised us as their children and their grandchildren. They built the society that we are now taking a part of, and we need to continue caring for them with dignity and respect with which they cared for us. We encourage the additional funding or refunding of the 17 positions with adult protective services, and we also would like to speak addressing the respite services. Caregivers for those with Alzheimer's in Georgia contributed over $221 million in higher health care cost. They take care of family members at no paid care. Unfortunately, many of them risk health issues to themselves. I am a former family caregiver for a mother and a grandmother. I developed health issues of my own as a result of the stress of caregiving for individuals with Alzheimer's. I would encourage a closer look at the health care needs of both the caregivers and the individuals with dementia. Thank you very much.
Is there anyone else who would like to speak? If so, please approach the podium and give us your name and the name of the organization you represent. Okay. I'd like to thank each of you for attending today's hearing. Now, would any member of the panel like to speak? Okay. I'd like to thank Senator Tim Golden, Representative Katie Dempsey and Sarah Dunn representing the House Budget Office, and Clay Buckaloo representing the Senate Budget and Evaluation Office. Now I'll turn it back over to Senator Tim Golden for closing.
Thank you, Demetrius. I appreciate it. Representative Dempsey, thank you for being here, and Sarah and Clay, and we appreciate everybody's participation today, and meeting is adjourned.